Let me open my slides. One minute.
Sumit, is everything all right? Can we start?
Yes, madam. Just opening my slides. Yes, has come.
Yes. Okay, just start.
Are my slides visible?
They're coming, yes.
Sumit, just start it and finish off on time because we will be breaking. We have to give the panelists the right time. So
Yes,
can
madam.
we just make it fast now?
Are my slides visible, madam?
Yeah, your slide is visible. Please go ahead.
Thank you. Good morning, everyone. Sorry for the delay. Today's first session will be best video session. I welcome all the delegates and our esteemed chairpersons and judges. Dr. Satish Mehta, sir, is consultant laparoscopic surgeon, GI surgeon, and therapeutic endoscopist from Ranchi. He has a very special interest in all academic sessions, and he has held prestigious positions in various organizing bodies nationally and internationally, like ASI and Hernia Society of India, Society of Gastroendoscopy of India, Indian Association of Surgical Gastroenterology. Dr. Vijay Kumar, sir, he's a he had he's consultant uh, general laparoscopic surgeon at Surya Super Specialty Hospital, Sahibganj. He has been an active participant in all the conferences, and he has organized CME and live workshop Jasicon 2011 at Sahibganj. Dr. Mohammad Azad, sir, he is consultant general and laparoscopic surgeon, Azad Nursing Home, Giridih. Uh, I congratulate sir for being the chairman-elect ASI Jharkhand chapter 2021 and 22. Coming to the rules and regulation, audience are requested to mute themselves in audio and video. Each speaker has 8 minutes for presentation and 2 minutes for discussion. Judges will ask questions. Audience can put their questions in chat box and not allowed to ask questions. Warning bell will be rung at 7 minutes 30 seconds and final bell will be rung at 8 minutes. So I would request Dr. Arshad Jamal sir, followed by Dr. Anshuman sir and Dr. Rakesh Chaudhary sir to present their videos. Dr. Arshad sir, over to you, please.
Should I start the screen sharing?
Yes, sir, please.
Okay. Am I visible? Hello? Hello?
You are visible, sir. You are visible. Please continue.
Okay. Good morning, everyone, respected chairperson and my dear viewers. A very good morning from RIMS Ranchi. I'm going to present my case about salvage of renal angiomyolipoma associated massive retroperitoneal hemorrhage using minimal invasive approach, a nephron sparing approach. Renal angiomyolopomas, as you know, it's a benign tumor composed of fat, smooth muscle, and blood vessels. A majority of them are sporadic. Most commonly occurs in a middle-aged woman, about 40 to 70 years. It's essentially a condition which can have flank pain, retroperitoneal hemorrhage, hematuria, and it is diagnosed usually by a non-contrast, unenhanced CT scan. Though fat-poor angiomyolopomas and retroperitoneal liposarcomas pose a diagnostic dilemma. Now, Window-Lynch syndrome is a retroperitoneal hemorrhage which occurs mostly due to a renal origin, and it is fatal in many conditions. About 20% of such cases present in shock, and massive retroperitoneal hemorrhage is a surgical emergency. which requires a partial nephrectomy or a total nephrectomy. It may be treated by a minimal invasive treatment like robotic partial nephrectomy or angioembolization. I'm going to present my first case. We encountered a middle-aged woman, about 45 years of age, in Department of Urology with complaints of right-sided flank pain for 10 days, severe weakness and gross hematuria for 2 days. On examination, pulse was 140, BP was low, 70/50, and respiratory rate was very high, 36 per minute. There was a massive right-sided palpable abdominal lump about 20 into 15 centimeters. She had a low hemoglobin, 4.8 gram. TC was 7,600, RBS was 80, serum creatinine was high, 1.9 milligram per DL. She was managed conservatively with fluid, inotropes, and 4 units of Paxil. This is the non-contrast CT scan. As you can see, there is a large right-sided retroperitoneal tumor with a retroperitoneal hemorrhage, and there were areas of necrosis in that, and it was a fat poor thing. This is a MRI abdomen of the same case, which shows a large mass on the right side, and it has areas of blood, and there was fat in the mass. Now, dilemma because of the acute renal failure, that because the serum creatinine was 1.9, we had a problem that what to do in such a case. There was shortage of blood also, and anesthesia was going to be a very high risk case. This case actually required a partial nephrectomy, but in this scenario, due to acute renal failure and shortage of blood and a high anesthesia risk, total nephrectomy was imminent, and a long-term renal function was a big question if a nephrectomy was going to take place. Now, we were wondering what to do. So our salvage came in the form of a savior called Dr. Prakash Kumar. He was an associate professor. He is an associate professor in Department of Cardiology. And with his support, we did right-sided renal super selective angioembolization. This is how an angiography is done. Our initial femoral puncture is done. An access is taken. A guide wire is deployed. 5 French guide wire goes into the aorta. Renal artery is hooked, over which a sheet is passed, and side port is flushed, locked, and through the main port, and is deployed. This is the flushing. This angiocath which is going inside, and through that a 5 French guide wire is deployed. This is how a renal angioembolization was done. This is first angiography, right-sided we did angiography, localized the site of bleeding. This is the site of bleeding, huge leak inside that, and then angioembolization using gel foam, and finally at the end of it there was no leak. At the end of third bolus there was no leak. Now coming to case number 2, she was also a middle-aged woman, about 45 years of age. She presented in Department of Urology, RIMS, Ranchi, with flank pain of 1 month and hematuria off and on for 20 days. Had a pulse of 90 per minute, BP of 106/70 mmHg, respiratory rate was 20 per minute. She had a palpable lump in the right-sided upper abdomen of about 15 into 10 centimeter. Hemoglobin was 9.8 and serum creatinine was normal. This is the non-contrast CT scan of the patient, which shows a large right-sided mass. And this is the CT angiography, which clearly demonstrates the vessels which are going below the mass. This mass was sitting on the mid pole and lower pole. So we did a right-sided renal super selective angioembolization. These are the pictures. First, a left-sided renal angiography to check for vascularity on the left side, which was normal. Then we did a right-sided renal angiography, and a large vessel in the mid pole and lower pole was identified. And finally, it was injected and the vessel supply was cut off. After that, a week later, then we did a partial nephrectomy for this case, and we found that intraoperatively the blood loss was very less. It was relatively avascular, and we could resect the mass properly without damaging the kidney. And this is the mass, which was quite large, about 15 into 10 centimeter. The cut section showed hemorrhage. And coming on to results, both the patients had resolution of hematuria and flank pain. There was no new episode of decrease of hemoglobin and hematocrit rate or hemodynamic instability, which was noted. First patient had an improvement in renal function, her bleeding stopped, and it is planned for a planned interval partial nephrectomy. The second patient also had a resolution of hematuria, and a successful partial nephrectomy could be done with a loss of just 200 ml of blood intraoperatively. So the take-home message is renal angioembolization can salvage a massive retroperitoneal bleeding and allows a more controlled environment for a planned partial nephrectomy. Renal angioembolization in a large angiomyolipoma can decrease the vascularity of the mass and facilitates partial nephrectomy. Renal angioembolization obviates the need of total nephrectomy for angiomyolipoma, which is essentially a benign condition. And renal angioembolization should be used for a nephron-sparing approach for the treatment of angiomyolipoma. Thank you very much.
Thank you, sir. May I now request the chairpersons to judges to ask questions?
Dr. Zamal, we normally see many cases who present with
Yes, sir.
angiolipoma, myolipomas. So, do you recommend
Yes,
some prophylaxis so that they don't land up in hemorrhage, or you just treat when they come with the hemorrhage?
sir, we recommend prophylactic angioembolization for large renal angiomyolipomas. Classically, renal angiomyolipomas are advisable for masses which are greater than 4 centimeter or 5 centimeter. These are the angiomyolipomas which are likely to bleed. And these angiomyolipomas, if they happen to have symptoms like flank pain or hematuria, then it is advisable to undergo an angioembolization outrightly.
What are the chances that minimal invasive surgery fails and you have to go for some salvage surgery or nephrectomy?
Sir, that's what I was trying to emphasize, that large renal angiomyolipomas, if it is fat rich, it is unlikely to resolve because of angiomyolipomas, because of angioembolization. But what angioembolization does is that it makes the disease quiescent and it allows a partial nephrectomy can be to undertake. That is the issue. If we try to do a partial nephrectomy without angioembolization, the bleeding is so much that in a frantic maneuver, the surgeon really ends up with a total nephrectomy. But a renal angioembolization allows the surgeon to dissect the plane, get the vessel control, hilar control, and once the hilar control is done, he can do a partial nephrectomy and a renal salvage approach can be taken. So we can do a nephron sparing approach more probably if with a greater probability if a renal angioembolization is done preoperatively. That is what I'm trying to emphasize. They will eventually require a partial nephrectomy, but the partial nephrectomy will have greater chances of success.
Dr. Jamal.
Yes, sir.
I'm Dr. Vijay.
Yes, sir.
Incidence of this tumor, how many cases you...
Can you speak a little louder, sir? Can you speak a little louder?
How many cases you are
Yes,
encountered with till your practice today?
We encounter a lot of angiomyolipomas, sir, but majority of the angiomyolipomas are small, less than 4 centimeter. Of late, we have encountered about 5 or 6 angiomyolipomas, which were quite big. These two representative cases were the biggest of them all, but we have seen cases more than 4 centimeter in about 5 or 6 occasions. But these two large angiomyolipomas were really outstanding.
What is the criteria to judge whether endoembolization is required or not?
The criteria is that if the patient, if the angiomyolipoma is very large, if it is sitting right on the midpole and on the hilum, and if a hemorrhage or a hematuria is there, then we should think about angioembolization first.
Okay. You did endoembolization by yourself with the angioembolization
Yes, sir.
yourself with the association of the cardiologist or cardiologist?
So it is essentially done by the cardiologist. We work as a team. but it is essentially done by the cardiologist.
Oh, nice, very good. Congratulations.
Right, sir. Thank you very much, sir.
With your permission, do I move to the next speaker? Dr. Anshuman is ready. We'll ask him to present on laparoscopic lateral pancreatic jejunostomy. Dr. Anshuman, please share your slides.
1 minute. Yes, I'm ready. Am I audible, sir?
Yes, you are audible.
Okay. So good morning, teachers, seniors, dear friends, and chairperson, sir. It's an honor to be in this August gathering. And now I realize that this stage fright is not limited just to stage. It can happen even at your own home. And thanks to the organizing team to accommodate me at the nick of time. So today I am presenting this video which I had operated around 3 years back. This is a lateral laparoscopic pancreaticojejunostomy with head coring. It is dedicated to God, to my patients and my gurus. The patient was a 33-year-old healthcare worker with recurrent attacks of pain since last 12 years. And as you could have noticed or not, the pancreatic duct was quite dilated. I will just come a bit back. I will show it again so that it can be appreciated better. Yeah. So as you can see, the pancreatic ducts were quite dilated and there were soft stones inside it. And the patient was having recurrent attacks of acute and chronic pancreatitis. So after due evaluation, he was taken up for the surgery. And coming directly to the port positions and the patient position, patient was taken into a modified Trellenberg position with a semi-prone position with a slight left 20 to 30-degree tilt to make our operations easier. The ports, generally we use 4 ports. These are the epigastric 5 mm, the umbilical 10 mm, the left and right mid-clavicular line ports. But in this case, I had used 2 more extra ports just above the lateral ports for better visualization of the ducts. So now I will just show you the port position. So this main 10 mm port is at the umbilicus. The epigastric port has been removed. And these 2 are the main ports and these 2 are the accessory ports I have made. Now the accessory port I have used also for the drain placement. I have, this is actually post-surgical photo. And one drain is at the LPJ jejunostomy site and one is at the pelvis. I feel in major cases, it is better to have a one drain in the pelvis so that in case there is some pelvic collection, it can be drained very well. So now it is, I'm confirming with a small gauge spinal needle about the pancreatic duct because this is the most critical step. Everyone fears that we should not be injuring some vessel. So after confirmation of the pancreatic duct, I'm opening this. So entire ductotomy is done using the harmonic as well as the monopolar cautery. Now I'm proceeding, as you can see, the ductotomy has been done. Now I'm proceeding with a bit of a head coring part. Actually, phrase or this is a hybrid procedure where we like to have a drainage procedure as well as some resectional part, not up to the sort of a beggar's procedure, but this helps in the patient in the longer run. So there were quite multiple soft stones present and we are aspirating as well as washing also. So some fluid will be visible. This is the wash fluid also. So as you can see, the duct is quite wide and these are the soft stones lying in the head region of the duct. So after confirmation of the head region, we have confirmed the tail region by putting a small feeding tube. And we have not stopped only at that. We requested our radiological colleagues to come and just confirm it using a trans-abdominal Doppler. So here, this is a trans-abdominal scan where we saw that there are, the duct is open near till the tail end. And there were few small stones in the head region, which we are going to remove further. So these are the small soft stones in the head region. We are removing it further. And we are continuing with the head coring using different instruments at our disposal, like the harmonic and the ligashore, as well as the monopolar cauteries. It is a very critical area, so it is. I'm going a bit slow, and also praying to God at the same time that I don't encounter any major vessels there. This is using the ligashore device. So now after that, I am forming the rule limb creation. We are seeing from the DJ flexure around 25 to 30 centimeter from the DJ flexure. We are dividing the, we are making the window, and now we'll be passing the vascular stapler load. I will cut short the video here because my video is a bit on the longer side. And here I'm doing a trans illumination. I think no one does it, but I do it to avoid hitting any vessels. So making a mesopolic window, I have used this trans illumination just to prevent any mishaps happening. After that, we bring the long limb of the jejunum into the pancreatic into the upper compartment. Some lengthening is required, so that we have done. I'm just fast forwarding a bit. So now I'm taking these stay sutures. The first stay suture is at the end, at the tail end. This is using Mercel 20. I feel 30 needle is quite sufficient here. But otherwise, laparoscopically, I feel 20 or 26 needles are better for all fine work. Apart from this stay sutures, there are a few more stay sutures I am taking with the seromuscular layer to the pancreatic capsule. I will try to fast forward that to save some time. So the stay sutures are now in place, and now we are making an enterotomy. Ideally, the enterotomy into the small intestine should be a bit smaller because small intestine is quite elastic, and we should not be overdoing that. Now using a PDS 20 30 needle, I'm starting the duct to mucosa anastomosis. Actually, it is a full thickness from the intestinal side, and taking a bit of pancreatic capsule as well as the mucosa also, because I don't want any pancreatic fistulas to develop at a later date. Actually, the extra port what I made, what I showed you in the early phase, it was having two lateral ports makes the suturing a bit easier.
You have 30 seconds to wind up.
Oh, I'm so sorry. So I will just fast forward it. Actually, I just wanted to show how we encountered a bleeding and how it was controlled. Actually, when bleeding comes and if you are using a continuous suture, we can just end it there and put a knot there. It's all right. So I will just come to the last part. So the same thing is repeated into the superior part also. And after that, we do a jejunostomy. And it will finish with the drain placements. And that's all. Okay.
Thank you.
Thank you.
Over to the judges, please.
Hello,
Yes, sir.
Dr. Anshuman.
Yes, sir.
I think you did side to side
Yes, sir.
pancreatojejunostomy.
Yes, sir. Lateral pancreaticojejunostomy, side to side, sir.
Side
With
to side.
hypotension.
Can we do side to end pancreatojejunostomy?
Sir, yes, sir. That has also been described, sir. And basically, it will be like a drainage procedure. Like we can do something like a distal pancreatectomy with splenectomy with a side to end anastomosis, sir. But the thing with these drainage procedure is, sir, that initially the results are quite good for in around 50 to 90% of the patients. But with time, the patients, some of the patients, they again start having these problems, And it has been seen if that we add a resectional procedure, the results is a bit better, sir. So it is, I feel it is a bit better for going a longitudinal pancreaticojejunostomy with some head coring. Praise has a bit of a limited head coring, not like a beggar's procedure. And I feel it is quite good for the patient, sir.
Oh, what is your take-home message?
Sir, I feel this is quite a good procedure, and the very good thing is that the patients they become so pain-free, sir, because chronic pancreatitis is a very debilitating procedure condition, and where the patient keeps on having recurrent bouts of pain, they are unable to work, they are unable to eat, and if you make them pain-free, they are really happy. And if you can do it laparoscopically, it is sone pe suhaga, sir.
What is the incidence of pancreatic fistula, post-operative pancreatic fistula in your series?
Sir, actually, I have a very few numbers, sir, of the total patient operated, but around the literature says around 5%, sir, 2 to 5%.
Okay, good.
Telling me a different formula or saying the formula.
Sir, questions, please. Are we done?
Nicely presented, Dr. Anshuman.
Thank you, sir.
And do you feel that means who are the patients who really need surgery? Means what are your criteria for taking up these patients? Because chronic pancreatitis, we see pretty good number of cases now,
Yes, sir.
and it is really, and as you said that many of these patients will come back with pain and other symptoms.
Yes, sir.
So you have to counsel them properly, and really the patient buys surgery when all the other modalities fail. So what are your criteria for selecting these patients for surgery?
Sir, my criteria is that the patient should really require the surgery. He is getting debilitated. He is really in pain. He wants the surgery. And my criteria for taking them surgically is that the duct diameter at least should be around 8 millimeters, sir. The wider, the better. But at least it should be 8 millimeters. Now, however, there are some procedures which are being described by Ibziki and all, where they are taking even up to 3 to 5 millimeter duct diameter. I'm not very comfortable at that diameter. I feel our endoscopic colleagues can do a similar job there.
Yes,
With the
endotherapy has a definitive role,
Yes, sir.
and so we have to select these patients, that who are the patients will be medically managed, endoscopically managed, and who are subset of the patients will need surgery. And as we have wonderfully shown that minimal invasive surgery,
Yes.
if you are skilled to do it, it has a definite role. Thank you very much. Any
thank you,
other
sir.
questions, doctor?
Thank you, sir. May we move to the next paper, sir, because we are lagging behind time. May I request Dr. Rakesh Chaudhary, sir, to please uh, present his slides. Dr. Rakesh, sir, please share your screen, share your slides. Dr. Rakesh was your, we can't hear your voice. The slides are not moving.
Rakesh sir, kindly try to reconnect your headphones, sir. We can't hear you anything. Rakesh sir, we can't hear you anything. You have to unmute yourself or try to reconnect the headphones, sir. Please. You are unmuted, sir, but we can't hear you anything. I think so. Earphone has some problem. We can't hear you anything, sir. Still. Unmute, sir. Hello. Sir.
Rakesh, was your slides not moving? We can hear you. Please move your slides.
स्टॉप शेयरिंग करके फिर से शेयर कीजिए.
Anand, please help.
Kindly stop sharing and then re-share.
So we can't hear anything from Rakesh, sir. I think so. They are facing some earphone problem. I think so.
Problem with the internet connection.
Yeah.
Let me call him.
Hello, Rakesh, sir. Yes, sir. We can hear you, sir. Try to change the slide, sir. Yes, sir. Yes, sir. Sir. We can see your screen. Try to change it, sir. Move to next page. No, sir. It's not changing. Yes, sir. Yes, sir. Now we can go it, sir. Now you can go it. Yes, sir. Yes, sir. Yes, sir. Your screen is changing, sir. Yes, sir. You are audible. You can go ahead, sir.
Okay, good morning, my seniors, and good morning. Yes, this is my first slide. Okay. Good morning, my seniors, my teachers, and my dear colleagues. Today I'm going to present this based video session. In this video, I'm going to show the meticulous decortication of environment is with complete lung collapse in present scenario and its outcome. In the background, prolonged tuberculosis or complete collapse of the affected lung is seen very often at the tertiary care center and Anapax Institute of the Jasicon. In the last 3 years, we have operated many such patients, but good point is that the meticulous decortication and repair of bronchopleural fistula leads to complete restoration of the healthy lung. This is a retrospective study, and the limitations are this is single institution study and having a small study pool. There is no conflict of interest. From 5 years to 70 years old patients were included in this study, 15 were male and 5 were female. Most of the patients have history of tuberculosis, and some of the patients have history of chest trauma. They presented to us with dyspnea of weight loss and sometimes symptoms. On examination, affected lung air entry was released, routine blood investigation, tuberculosis test, chest X-ray and CST thorax, then preoperatively. In few of the cases, we found bilateral involvement. We optimized the patient by chest therapy and respirometry before surgery. We operated upon more severely affected lung with immediate lung restoration and follow-up, so good results with no recurrence. Under general anesthesia, with sometimes thoracic epidural and routine intubation, we entered the thorax through the fourth or fifth intercostal space by anterolateral therapy, extended the incision as required in the course of surgery. We found the thickened pleura leading to complete collapse of the affected lung and thoracic cavity, full of debris and stuff. We gently started decortication from the middle lobe, gave vertical and horizontal incision over the thickened pleura, and released the compressed lung cranially, caudally, anteriorly, and posteriorly in sequence. Check the air by inflating the affected lung list. If we noticed any visual air, then we closed the bronchopleural fistula with 4-0 proven sutures. This is the chest X-ray of the patients, showing almost complete white out of that lung with features of hydrophorex. And the CT scan is also showing this, was also showing the same. This is the basic before starting the surgery, but how the patient left side was up and the patient was in position. This is when we entered the thoracic cavity. What we found, the thoracic cavity was full of almost 2 liters of stuff, and the entire thickened pleura was adhered all around, and there was no lung almost. We thoroughly washed the thoracic cavity with the lukewarm saline 3 to 4 times to clean all the debris.
Dr. Rakesh Bose, your voice is not audible. Can you please remove your microphones and speak on a speaker, please?
Yes, now it is audible.
Yes, it's much better.
Okay, so this is the small loop of video where we were showing that how the thoracic cavity was. The entire thoracic cavity, entire lung was, there was no lung, and entire pleura was fixed to the hilum and upward, and the entire thoracic cavity was full of debris and slough and pus. This is how we do keep the cruciate disease in the, at the level of island. And this is how we keep the cruciate incision at the level of island, and we usually start decortication in the sequential manner. What you did now. The anesthetist was ventilating the lung in the gentle manner, and the lung was appearing, started appearing. This is just after starting the decortication. After some time, when we decorticated the hilar region, we will go, then the lung started coming. And this is the video at in between the entire lung was decorticated in a sequential manner. And initially there was no lung. Now at the end, entire thoracic cavity was full of lung. Lung was expanding well, and we have checked the entire lung for the bronchopleural fistula or any major leak by putting the normal saline, warm normal saline inside the thoracic cavity. If we found any major leak, we close the leak in at the end. The thoracotomy was closed in a sequential manner in the layer by layer, and at the end, we usually put the subcutaneous sutures with a protein, and we usually put only single drain on 24 or 28 sides of body drain to drain the thoracic cavity and the receptor.
You have 35 seconds to wind up.
This is at the last, the patient extubated on the table before sending to the ICU, and in ICU, usually say the patient that do the experiment in the proper. So we never excised any, we not required to do lobotomy or nephrectomy in any cases. While addressing the take-home messages, while addressing hemodialysis, proper planning, prior optimization, family and meticulous decontamination is the best to keep excellent results. Thank you.
Thank you, sir. Over to the judges, Dr. Azad sir, Dr. Satish sir, and Dr. Vijay sir. Please ask questions. Hello.
Hello.
Judges, please ask questions.
Hello.
Hello.
Dr. Rakesh.
Yes, sir.
Hello.
Hello. Yes, sir. Am I audible, sir?
Did this case report, you have told that 20 cases you operated. Out of 20, 14 of coughs and 6 was of trauma.
Yes.
In all the cases, you didn't require any lobectomy or pneumonectomy, as you have mentioned that you did decortication and no lobectomy or pneumonectomy was required.
Yes.
How was the outcome in all the cases? What complications you faced?
In one patient, what we found that the patient was having hemoptysis later on, after almost 3 months of surgery, he came to us with single episode of hemoptysis. And in one patient, what we found that the patient was having wound infection, That's the complication we have noticed. And at the end of 6 months, almost there was normal healthy lung in all the patients. The entire lung were expanded and working in a proper way. What we have given the message to the patient that he should continue the respirometry at the home also, so the lungs should the lungs should remain healthy and there should no restriction at all in the post-operative. And in tuberculosis
Dr.
patients,
Rakesh, I am Dr. Jha.
okay, sir. Good morning, sir.
Morning. Congratulations for this. One question only. Which part of the state you get such type of cases? Which part of the state of Jharkhand? That is demographic question. Which part of the state? Mostly?
Mostly it is from 3 cases from Bokaro and 4 cases from Sahibganj and Dumka and
So, to start with, you just have demographic picture because the volume of your cases increasing, and it will help us and the juniors also for the further follow-up. Okay, that is my message. Thank you. Good oration. Good video. Keep it up. Keep it up. Bye.
There are no more questions from the judges. We move to the next part. I thank Dr. Satish Mida sir and Dr. Mohammad Azad sir for being a part of this session, to judge the session. I also thank Dr. Vijay sir who have timely intervened and judged the session properly. Thank you all. Now over to the next session.
Shall we start?
Over to you, sir. Over to you, sir, please.
Welcome to the panel discussion. I hope our panelists and moderators are present here. I invite Dr. Ramesh Agrawala sir to kindly take the chair, and he's our chief moderator for the session.
Thank you very much. Am I audible?
Yes, sir, you are audible, sir.
Yes.
Our co-moderator is Dr. Satish Mida. I welcome you, sir.
Thank you very much. Good morning, everybody.
I also welcome our panelists, Professor R.G. Bakla, sir.
Thank you, Dr. Pandey.
Dr. Nirmal Narayan, sir, from Patna. Dr. Narayan, sir. Dr. N.P. Narayan, sir. Dr. Tarun Mittal, sir, from Delhi.
Hello, hi everyone.
Yes, I'm here.
And Dr. S.S. Chauhan, sir, from Jamshedpur. Dr. Chauhan, sir.
So, thank you very much, Dr. Pandey. Can I take over now?
Yes, sir. Kindly take over, sir.
Yes. Thank you very much. Good morning, everybody. At the outset, I would like to thank Jasicon, Arima, Sunil for this wonderful conference and giving us the opportunity to be a part of this excellent conference. Jharkhand is very, very close to my heart. My sisters are married in Jharkhand, and I have often been to Jharkhand for different live operative workshops and otherwise. So it's a very, very close to my heart. Now, this panel discussion is about complications in hernia surgery. So we are going to talk about both groin hernia surgery and minimal ventral hernia surgery. We've divided this into 2 parts. One is for open surgery, one is for laparoscopic surgery. So the open surgery is going to be taken up by my co-moderator, Dr. Satish Mida, who is a prolific surgeon, very senior surgeon who needs no introduction. He will take you through the panel discussion for open surgery. And after him, I will do the laparoscopic panel discussion. So over to you, Dr. Satish, for the panel discussion on open hernia surgery. Yeah.
Yeah, Dr. Sushil, is the introduction part over? Then we can, if you can stop sharing, then I will start my screen. Can you hear me?
Yes, Satish, we can hear you.
So we will start the discussion about the complications of the hernia surgery. This has been prepared jointly by me and Dr. Narayan from Patna. I hope we can see him. We know that hernia is a very common surgery, and it is done by all surgeons in all cities, small places, and it can be done as elective surgery as well as emergency surgery, both inguinal as well as the anterior wall hernias. And especially in inguinal hernia, we are using GA, LA as well as regional. So we have to have these facilities, and laparoscopy is mostly done under GA. The first and foremost important thing when dealing with the complications is that informed consent is a must, especially in the present era. Patient must be told about the following things when we are going to operate him: about the recurrence, common problems like bleeding, infection, scars, possibility of chronic pain, testicular artery injury, or sometimes if there is obstruction or you are suspecting some gangrenous changes, some bowel resection, anastomosis, and even sometimes stomas also, and the problems associated with anesthesia, cardiovascular, respiratory, and other problems must be kept in mind. Inguinal hernia is done under LA and regional anesthesia. Dr. Bakla, can you hear me? Hello? Hello?
Yes. We can hear you, Satish.
Dr. Bakla.
Yeah, I can hear you. Can you hear me?
Yes,
Yes,
sir.
yes. So
Yeah.
what is your, just I would like to know that what is your usual preference while doing an inguinal hernia? Would you go for local anesthesia or regional anesthesia?
I'll go for regional anesthesia.
Usually regional anesthesia.
Yeah.
Any difference of opinion, Dr. Tarun Mittal or Dr. Narayan? Always regional or local?
Sometime in high risk patients like COPD and severe heart failure or chronic liver disease, we have undergone under local anesthesia also. But yeah, preferable would be regional, but in some special situation, local also.
So the general consensus is that mostly inguinal hernia repair is done under regional anesthesia, but there are few school of thought who always do the nerve block and do under local anesthesia. There are various clinics like Sholdy's clinic. They usually perform most of their surgeries in the local anesthesia. And as we know, there are several techniques available, and use of mesh is a must in present era. Uh, Dr. Agarwal, would you go for open hernia repair without mesh in this era? Still, can
No,
you can you do?
I don't think so. Mesh is a must, uh, except in cases if there is infection, if you are doing a recurrent hernia where you're explanting the mesh, you just might, because if you have a risk of strangulation again, so you can temporarily close with suture and later on you can put in a mesh, but otherwise there is no role of only suture repair.
So in the present era, the use of mesh is a must. It has been shown in several studies that if you are not using mesh, the incidence is as high as 30%, 40%. So to bring down the uh, recurrence rate to zero or even less than 5%, so use of mesh is a must. So there are various intraoperative complications like injuries to vital structures like vas, blood vessels, nerves, bladder, gut. We have to be more careful while we are dealing with the sliding hernias when the contents may come down and sometimes we may appear something as a wall and it may be just bowel loop and obstructed hernias also. So we have to be extra careful. Dr. Bakla,
Yeah.
what precautions would you take so that VAS is not injured in the because some youngsters when they are going for hernia surgery, even they would like to know whether this is going to affect their fertility. So, what precautions would you take in the open hernia repair while handling the VAS so that it is not entrapped in any sutures or it is not accidentally even divided? Sometimes we have seen uh, sometimes VAS has been accidentally divided also during dissections or too much handling has been done. What is your way of doing these dissections?
First of all, I will identify the sac, hernial sac, which is usually
Yes.
the indirect type anterolateral aspect. As is that is present over the posterior aspect of the spermatic cord. Therefore, identifying the vas as well as the blood vessels, I will separate or dissect the sac up to the neck of the sac. So identification of the vas and separation of the sac.
Earlier,
Yeah.
so that is very important that sac must be identified properly and we must stay close to the sac. And then if we are close to the sac and separate the structures from it meticulously, so we will not be injuring the cord structures and the vas, which will again go away. And then if there is a direct hernia, you just push the sac behind. If there is an indirect hernia, we go up to the neck and then ligate the sac. Dr. Narayan, have you joined?
Yes. Yes, I am here.
Yes,
Hello.
Dr. Narayan. Yes, sir. Nice to see you. Good morning, sir.
Good morning.
Earlier, sometimes people even used to do deliberate orchidectomy so that recurrence is not there, especially in the older people. So, what is your take nowadays that still it is practiced, or we should try to preserve the testis in all cases and prevent injury to the testicular vessels?
No, once we are using the mesh. Hello. Are
Yes,
you
yes, sir.
listening?
Yes, yes, we
Hello.
can hear.
Yes.
Yes, we can hear you.
Once we are now using the mesh. Earlier we were not using the mesh with a high recurrence. Once we are using the mesh, we must attempt to preserve most of the cases. In most of the cases, to preserve the testis, unless it is really required, unless there is a recurrence and it's in a bad situation. Otherwise, in most of the cases, I personally feel that to preserve the testis will always be rewarding. The patient will be happy. Otherwise, they feel that they are lacking something. So it's my personal feeling. But in very old patients, or where we feel that recurrence will be there is an obstruction, then in that situation, with the proper consent of the patient and the relatives, we can do an orchidectomy.
Dr. Mittal, if supposing a junior resident is operating and he has divided the testicular artery, so
Yeah.
what do you do? We can leave the testis. Will it get the blood supply from here and there, or will it atrophy? Will it be useful?
See, what the literature says is, if you are more farther from the testis, there are more chances of the collaterals being there, and the testis can survive also. If you are dividing just at the level of the testicular vessels which are entering into the testis, then the chances of ischemia and atrophy are more. If it has been divided, generally it is non-repairable. You can try with the plastic surgeons with if they can attempt this, but I have never attempted that. But if it is far from the testis, the chances of testis being survived, and anyhow we have the other testis which is normal. So generally patient will not have any issue.
Dr. Bakla, thank you very much, Dr. Mittal. What means, one of the problems with the patient is the neurological pain. So what do you normally do with the ilioinguinal nerve which comes in there? Do you try to preserve it, or even there are some people who even carefully divide it so that it is not entrapped? And some means there are various policies. I have seen various surgeons operating. So what is your way of doing, preserving the nerves, or just dividing them so that they are not entrapped? Especially the entrapped nerves are usually the cause of chronic neurological pain in that groin area.
Yes, Dr. Amit, the entrapment of nerves, that is very important. Not so usually I try to save nerves, but sometimes I do sever them.
Okay.
And there is no complication after that, post-operative complication.
Any difference of opinion among the panelists regarding the preservation of nerves or routinely dividing them?
I would like to, yeah. Someone is saying.
Yes, I will like to preserve it as far as possible. If it is unavoidable, or if it is badly adherent, or I feel that unless I divide it, I cannot separate the sac and cord, then only I will like to divide. Otherwise, all efforts should be made to carefully preserve it.
There has been a lot of studies in this, and the lowest rate of groin pain is there when you have identified them and preserved them. If you identify them and cut them, and you identify them and you do not preserve them, then also the incidence of chronic pain is higher. So identify them and preserve is the best way forward.
So it is very important that we should have a clear field of dissection, and each and every structure should be identified, the nerve should be identified, and then especially while we are closing the structures, putting the structures back, then only when we are suturing the inguinal ligament and all, then only these nerves are usually entrapped. Coming to the common post-operative complications which come across are the seromas, persistent of swelling, sometimes lipomas also, pain, recurrence, and the mesh issues. So, Dr. Bakla, how common are the seromas in inguinal hernias in your practice?
It is not very common, and usually if it develops, then that subsides after 2 to 3 weeks, like that.
And if you see lipomas, means would you remove all of them, or because sometimes if left, they can cause problems also?
No, lipoma, that is being excised.
Lipomas you will always excise. So compared to the laparoscopic surgery, the Dr. Agarwal, what do you feel that compared to laparoscopic surgery, the incidence of seromas is less in inguinal hernias because we are doing less dissection.
Yes, yes, I think so, because we don't see seromas so common in open surgeries as commonly as we see in laparoscopic surgery. So seromas is, I don't think, is much of a problem in open surgery.
Recurrence, I think that we have to keep in mind, it is also surgeon dependent. So technique is variable. So we have to take all the measures to bring it down. Mesh we will take up when we are discussing the laparoscopic surgery with Dr. Agarwal, because this is a common issue which comes in. But overall, Dr. Mittal, what do you feel the mesh infection is less in inguinal hernias compared to the anterior abdominal wall hernias? Your take, especially Dr. Mittal. Can you hear me, Dr. Mittal? Hello.
I can hear you. Yeah, I can hear you. What is the question?
Compared to comparing the ventral hernias and inguinal hernias, are mesh infection rate lower in inguinal hernias? What do you feel?
In open surgery, definitely it is lower because you are not dissecting so much. Flap is not being raised in inguinal hernia vis-a-vis in ventral or incisional, where incision has been given. Lot of flaps are raised in open only meshes. So higher incidence would be there compared to inguinal hernia.
Okay. So these are the list of complications which Dr. Narayan has compiled for us. So I think we have dealt with most of these, and late complications are less common compared to the. Coming to the open anterior abdominal wall hernias, still it is most of the surgeons in our country are doing by the open technique also, especially the larger ones. And sometimes defect may be very large, there is loss of domain, and we may need a teamwork with the involvement of the plastic surgeons, and sometimes the anterior wall reconstruction is a must. Dr. Bakla.
Yes.
If a patient comes with anterior abdominal wall hernias or incisional hernias, what is the size where you will say that these have to be done by open surgery and should not go for laparoscopic surgery? Any criteria in your unit or in your department?
If the size of the hernia that is more than 12 centimeters, I think that is our limit.
Okay.
We go for open surgery. More than 12 centimeters of the defect.
Now even anterior wall reconstruction is evolving as a specialty. Dr. Narayan.
Yes.
When do you need the involvement of plastic surgeons? Like you need to perform procedures like abdominoplasty or something like that in a very huge hernias?
I mean, in general, if the volume of the sac is more than 25% of the volume of the abdominal cavity, we must be prepared that we will need proper dissection, proper mobilization, and we have to take help of the plastic surgeons. And on top of it, it should be done where we have got facilities of ICU also, because sometimes with the reduction in compression, we can have an respiratory distress. So the patient has to be explained all about it, that this is a big volume. After reduction, we will do our best, but you may need further respiratory support.
Dr. Mittal, as Dr. Narayan has pointed out that you have to know the volume which is out. Do you sometimes make some pre-operative consideration so that you don't land up with the complications of this compartmental?
In any complex hernia, we get a CT scan done. And after, if loss of domain is, we are feeling that there will be loss of domain, a lot of intestine is there in the sac and less in the intra-abdominal, most of the time we do a Botox injection pre-operatively, and after 6 weeks we operate. We have tried progressive pneumoperitoneum also, but that is little painful for the patient and has repetitive and if pain is not required, then repetitive anesthesia has to be given, and there are some complications also. But with Botox, we have not have any complications. There is a well-defined technique of injecting all the three muscles, both side, right and left side, at 3 points. So 9 points in left side, 9 points in right side, and then the muscle relaxes. And after 6 weeks, we operate them. So chances of the abdominal compartment syndrome and closure is less, and the closure become much easier to do. And sometimes, obviously, in all these patients, we would have to be prepared for doing a component separation with transabdominal release, posterior component separation, or anterior component separation. Thank you.
So thank you very much, Dr. Mittal, for bringing out these points, especially for our young surgeons. So we have to know these newer developments which are taking place in the anterior wall reconstruction. So you can see some of these present hernias may be something like that, and where we have to go in. So these are the various types of hernias which we come across. And in incisional hernia, our idea should be that we should approximate the musculofascial layers and with the minimal tension, and use of prosthetic mesh is a must, and mesh can be placed in the different planes which will come across now in our subsequent slides, and mesh should be large enough to have the 5 centimeter overlap on all sides, and mesh should be fixed with staplers and sutures, and sometimes we must take measures to prevent injuries to the bowel, bladder, and mesentery. Dr. Bakla,
Yes.
Where would you like to put in the mesh?
I place in the retromuscular area.
You place in the retromuscular area. So this is very important, that this is the best plane which we have. Dr. Narayan, what is your preference?
I also prefer that, but if I can approximate the seat, then I usually place the mesh between the seat and the muscle. If I can approximate it, if I can approximate the seat, or if required, we can resect the larger volume of the omentum and all. If it is all soft and I feel that there will be no tension, then we can place the mesh between the sheath and the muscle, and we can approximate the seat. That should be the best one.
Is Dr. Chauhan here?
Yeah.
Sorry, I
agree with him. I agree with Dr. Narayan's view that retromuscular plane is the right plane, and
yes.
We can also consider excising the bulky omentum to decrease the volume and facilitate the abdominal closure.
So how much mesh would you fix? What are your fixation policies in the open hernias? Means to prevent.
So, yeah, I would like to be fixing the mesh all around.
All around. And would you like to drain the areas after the dissection, or
yes?
Since there is a fair
amount of flap would have been dissected. Yes, since there would be a fair amount of flap which would have been dissected, so it will be a wise idea to keep a suction drain to prevent any hematoma getting collected.
Dr. Agarwal,
yes.
If a patient comes post-operatively with some seroma-like collections when we have removed the drain, so what will be your management? Because the patient is worried that I have developed a swelling in the hernia area again, and especially if he goes to another surgeon and the surgeon may tell that your hernia has not been operated well. So how would you counsel these patients, and what will be your management?
You have to, it's just reassurance saying that this is a common post-operative event which does not need any surgical intervention and which subsides with a period of time. And the fact that he has to be patient and we have to be patient, and we have to wait for at least 6 weeks to 3 months. I think if you do that, and if necessary, if he is still not convinced, you can do ultrasound to show that there is only fluid and there is no recurrence of hernia. That is the only way. And if you want to refer, you want to take a second opinion, you can ask him to take a second opinion, but choose one of your friends who is not going to misguide him.
This is the large incisional hernia which we have already dealt. Dr. Chauhan, what preoperative counseling is a must, especially in this era for incisional or anterior wall abdominal hernias?
Yeah, you see, all incisional hernia are prone to recur, and particularly if you're already operating a recurrent hernia, there is always a chance of recurrence. So patient should be always counseled about recurrence. He should be counseled about a possibility of gut injury which is occurring, because these are incisional hernias which may be densely adherent. So there would be a possibility of gut injury which can take place. And then you will also have to tell them about a foreign body sensation which may occur after placing a large mesh, a possibility of a seroma, and other wound related complications.
Thank you. Dr. Narayan,
Yes.
just your take on the, especially for the younger surgeons, about the intraoperative techniques like dissection techniques, hemostasis, and flap necrosis to prevent the flap necrosis, etc.
Yeah.
What are the
I
steps would
mean,
you take?
what I feel that the dissection has to be meticulous, and whatever flap, skin flap, must have that amount of fat. We must assess that this flap is going to be viable. Otherwise, just dissecting is not going to serve the purpose. We should raise the flaps in proper thickness so that after we close it, the flaps take. Or when we find that flaps will not take, then those flaps are to be better resected. And then, but on top of it, we must have in our mind that approximation has to be there. So if approximation will not be there, then we should go for component separation and all we have discussed earlier. So tension free, the basic idea is that the anatomical closure, first thing, anatomical closure and tension free closure is the key point. I mean, if we can approximate the peritoneum, the muscles, the sheath with the mesh, this is the best one, the anatomical closure, but all should be without tension. Because if it is with the tension, then the chance of recurrence goes very high. Those parts will expose and ultimately fibrose and will lead to recurrence. That is my idea.
Professor Bakla, what steps would you take to prevent the wound complications? Because this is a very important issue. Many of the patients will come with the infection, and sometimes it takes months for these wounds to heal.
So strict aseptic measure that should be taken right from the beginning. And then there should be appropriate hemostasis, as well as there should be gentle handling of the tissues. These three things are very important to avoid post-operative infection.
Dr. Chauhan. Dr.
Yeah, most
Chauhan.
of the points have already been covered about meticulous hemostasis, changing of gloves, irrigating the mesh with antibiotic solutions, prophylactic antibiotics, not carrying with a mesh hernioplasty in case you have a bowel injury or some gut operative field contamination. So these are the usual precautions what we would like to take.
So recurrence is one of the important issues which we have to keep in mind, and we have to counsel these patients. Mesh issues we will deal separately, and these are the points which we must remember, that there are different types of mesh available, and these are the complications. Time is less. We will move to the just one issue before we close down the open hernia and move to Dr. Ramesh Agarwal. Dr. Professor Narayan.
Yes, sir.
Hello.
Yes, yes. Hello.
What do you think that important points in the training to have the better
Sir,
outcome, especially
sorry
in the
to disturb. Sir,
Training
Ramesh
is
sir, you want to talk to me?
Training is very, very important. Just because we feel that hydrophile and hernia are simple operations and we just leave it to our first year postgraduates are house surgeons. No, initially, at least 5 to 10 cases he must do with me. I mean, I must train him properly. I must train about the anatomy of that hernia, about the mobilization, about the closure, about the fixation of the mesh. Everything is important. The initial training is so important that uh, that the outcome of the patient, whatever he will be doing, will all depend on how he has been trained. So I personally feel that initially all our students, all postgraduates, they must be properly trained for hernia.
So over to Dr. Ramesh Agrawala to start the other. I think rest of the things will come as many of the things will be common. Dr. Ramesh.
Yes, thank you very much, Satish. I'll just share my screen. So, Satish, can you see my screen?
Yes,
Yes,
we
sir,
can
we
see
can
now.
see yes, yes.
Yes, yes. So thank you very much, Satish. We've had a very interesting session on open hernia surgery, and there's going to be quite a bit of overlap because basically the fundamentals are same, only the approach is different, and laparoscopy is only a different way of doing it, but the principles of surgery remain. So I have no disclosures except many of the videos have been contributed by my colleagues, and all of the videos are not mine, and I would like to acknowledge their contribution. The panelists, we are already aware, these are the 5 panelists we have. So what we are going to look at, not only complications, also special challenges which will come across, and we'll divide the session into preoperative, intraoperative, and postoperative. So for the first scenario, we'll have different scenarios. So Dr. Chauhan, I will come to you for the first scenario. Female, 35 years old, planned IPOM plus for a 3 centimeter paraumbilical hernia. Preoperatively, we always do ultrasound and we find gallstones in this patient. Now, what would you do for the gallstones? Would you operate for the gallstones and then do the hernia, or you will just do the hernia and leave the gallstones as it is, or will you do both of them together? Dr. Chauhan?
Yeah, usually when since we are going to place a mesh and the defect is more than 1 centimeter, it is 3 centimeter, we'll be placing a mesh. And we really don't know how easy or difficult the cholecystectomy is going to be. And also there is always a possibility of bile leak occurring. So I would not like to combine another operation along with a mesh hernioplasty, though there are different views. Many people do combine because that saves the patient of another surgery. But then when you do that, you have to be extremely careful and do not use the mesh in case there is a stone spillage or there is pus or there is empyema or there is some other problem, because then the mesh infection rates will go up. Also, you have to very carefully site your ports because you will be now doing 2 different surgeries and you may have to site your ports accordingly.
So even also we have this standard teaching that a symptomatic gallstone should not be operated. So we need to counsel the patient that if you need a surgery for the gallstone, the ports might have to go through the mesh, because if the mesh, because it's a paraumbilical hernia, so we might have to put the ports through the mesh. But Dr. Chauhan, if the patient is symptomatic and the patient has symptoms for gallstones, any requests that would you do it for both together? What would be your take in this case?
Yeah. So then there is always a possibility in case the cholecystectomy since it's a symptomatic cholecystectomy, it can turn out to be a difficult cholecystectomy. It can turn out to be an empyema, or there may be other issues. So if it is not a straightforward, plain and simple cholecystectomy without any bile or stone spillage, then I would like to do it differently, a symptomatic particularly.
Yes. So what we can do is we can do the gallbladder and do open hernia repair. That is one possibility, or do the gallbladder and then ask the patient to come after 6 weeks to do the hernia. So these are the possibilities which can be done. So Dr. Narayan, this is for you.
Yes.
45-year-old female, BMI of 40, 4 centimeter umbilical defect, M3, unable to lose weight. So normally our standard teaching is that in obese patients, since the recurrence is very high, we should ask them to lose weight. but many of them are unable to lose weight. So that we can ask them for a bariatric surgery, but they are not willing for a bariatric surgery. And they also feel that the doctor has become greedy. I have come for this and he wants to give me 2 surgeries. So what would be your difference in management compared to a non-obese patient? You have to operate on this patient. So how differently will you do in this case?
I mean, the first thing is that pre-op we will encourage her to reduce weight with the help of dietitian. All so reduction of weight initially we can, if we can delay the surgery, there is no obstruction, nothing like that. So if we do it after reduction of weight, proper respiratory exercises, and then we plan for the surgery, that will be certainly with a better outcome.
Yes, I agree with you totally. And if the patient does not comply or fails, I think this should be totally documented in your records that you've gone through this. Because if the patient has recurrence and they say, why did you operate on an obese patient? Then you have this documentation. Moreover, this mesh size would be bigger than what you would use in a non-obese patient. So Dr. Bakla, this is for you. 34-year-old male, umbilical hernia, 3 into 4 centimeter defect. Again, IPOM plus. And you know, when we have these central abdominal defects, we use a Palmer point axis, which is 2 centimeter below the left midclavicular line. So what precautions would you take before going through the Palmer's point, Dr. Bakla?
So proper antiseptic preparation of the skin, as well as this is laparoscopic surgery. Then we'll put the ports.
Yes. So Palmer's point, whenever we do, it is very important that we should see the Ryle's tube is put in, because the stomach, if it's distended, then you might go through the stomach. And you should always palpate for the spleen, because again, you would go through the spleen. So we have, these are the different precautions you have to take. We have different methods of access. One is the Varies access, the open port, and OptiView. So Dr. Midda, which point of access would you prefer? Different methods you can access the abdomen. Dr. Midda, you are silent. Dr. Midda, you are silent.
Hello.
Yes. So what would you prefer? What would you say that this is the main point of access?
In the Palmer's point, usually I go by the Varus needle, and if you have the OptiView, you can go for the OptiView.
So what I want to say is you use an axis which you are comfortable with, because all axis will have complication. You can see this video on the left. This is in the stomach. The port is in the stomach. We gone through the Palmer's point. It was a thin patient. The anesthetist had not put in a Ryle's tube. So you can see the port has gone into the stomach. So this is one of the complications which can occur, which one has to be careful about. And here you see a lot of people who advocate OptiView. They feel that OptiView is safer. This is again by a very senior surgeon, and he's used OptiView, but you see he's gone into the intestine. So 50% of the complications occur in excess, which is very, very important. So this has to be understood, that you may be bowled out on the first ball. So one has to be very, very careful. So Tarun, you see this is sometimes when you go inside. Tarun, you have
Yes, sir. Yes, sir.
You see a bowel like this,
Yes,
right?
sir.
So what precautions would you take in a bowel like this in laparoscopy to prevent enterotomy?
Yes, sir. So basically, your instrument should be atraumatic. That is one of the most important thing. You should always, when you are stretching the bowel, there should be atraumatic instruments, and you should never use an energy source. It should be a cold scissor, which you should use, and always try to dissect one layer above the bowel. You can take peritoneum or a sheath also along with the bowel when you're doing a disolysis, instead of taking a bowel with the peritoneum. If you take these precautions, and you should be very gentle with the bowel, maybe use different views. Sometimes the angle might change. You might seeing one view, you might see that it's not bowel, but from behind it can be bowel. So you should keep changing your views, and slowly and steadily with patience, most of the time you will be able to dissect this, whatever form adhesions it might be.
So the main thing is, Tarun, as you said, is the plane. You have to go one plane above. As you can see in the video, we are taking a bit of sheath with the bowel. So you don't dissect between the bowel and the peritoneum. You go one layer above. And then you should always check if there has been any enterotomy. So, Satish, this is for you, 52-year-old female. Again, laparoscopic incisional hernia repair. And you see, the surgeon is not following the principles which Tarun has said. So he is just trying to dissect between the bowel and the abdominal wall. And he's got an enterotomy. So what would you do to the enterotomy, Satish?
We should dissect the remaining part of the gut and properly assess the injury which we have done and immediately repair it. We should not leave it for later part of the surgery.
So you repair, this is the first step. You repair the enterotomy either by open or by laparoscopic method, whichever you are. And what would you do to the hernia, Satish?
In this case, since enterotomy has occurred, ideally we should not put in a mesh. If need be, we can do the anatomical repair or some hybrid combinations and come out or tell the patient that we will complete the procedure in the next session. Or there is a role of biological mesh, which is again debatable, and also especially involves a lot of cost in our country and usually not also readily available also.
Yes.
Biological meshes, especially.
So what happens, Satish, people don't have a biological mesh in their OT because the hospitals do not want to keep an expensive mesh which is not frequently used. So they will not have it in the inventory. Some people do repair the hernia on the premise that there is a minimal spillage or a small bowel spillage, but it is always preferable not to repair the hernia at this time because this would cause much more problem. So what you do is you can see that it has to be repaired immediately. If you are good in laparoscopic suturing, you can repair then and there and not wait. So
I would like to add few points here.
Yes, tell me.
One thing you should always do is separate all of the bowel. If you have just separated this, enterotomy has happened and other adhesions are there and you have not separated them. So if you are going next time, then also you will encounter those. So try to separate all those adhesions which are there. And second, what thing people do is there are two thoughts. Some people after 7 days also go in and do the IPOM repair, or then otherwise after 6 weeks you can go and do the IPOM repair or any repair which you want to do.
So the basic idea is once you are sure that there is no infection, you don't mind putting in a mesh. So Dr. Nirmal, this is for you, 55-year-old female, obstructed or incisional hernia. Now, what would you do? Would you do laparoscopy? Would you do open? Would you do a hybrid approach? Dr. Nirmal, your phone is, you are muted. Dr. Nirmal, you are muted. You have to unmute yourself. Dr. Nirmal, you have to unmute yourself. Yes.
Hello.
Yes, tell us.
Yes. Once there is obstructed hernia, there can be a strangulation also. So in all the cases of obstructed or a strangulated hernia, I will prefer not to go for a laparoscopic surgery. Explain to the patient, and I feel that an open surgery in those cases will be better. Unless the operating surgeon is very confident and has got a good experience, to start with, we should not try for a laparoscopic surgery.
Yes. So I agree with you. It depends on your expertise. It's always preferable to do open, or you can do a hybrid approach where you do open, reduce, and do it. So, yes. Dr. Nirmal, you saw this video, and what would you do to the bowel in this case?
So it is part of it is gangrenous. So in that case, the resection anastomosis has to be done.
Yes.
And the best option will be to go for a hybrid, to open it, do a proper resection anastomosis, and leave, not putting the mesh, and explain to the patient and the relatives. For the next session, we will deal with the hernia.
Yes, yes. So in this case, definitely, Dr. Nirmal, I agree with you that we cannot put in a mesh. We have to maximum, because it was obstructed hernia and can get obstructed again. So what we have to do is maybe we do a suture closure, which can be done. Which can be done.
Dr. Agarwal, I had a small point. In these cases, would you like consider doing a component separation and avoid using a mesh totally? Would that be an option? Which you will consider?
This wouldn't be an option, because it's a very small defect which would not require a component separation. So component separation is basically we do if this defect is big. So the only thing is suture closure, do the resection anastomosis, let the patient recover, because you will have toxic fluid there, and it is also not advisable to do open repair. So we would not prefer to put in a mesh anyway in a case where there is a gangrenous bowel. Satish, this is for you. So when we try to tack, you see, Satish, then we have this bleeding sometimes, right? When you are putting a tacker. So how do you prevent this bleeding?
Firstly, when we are doing the dissection, we should identify the major vessels. So we should have an idea that where these vessels are running. So we should try to prevent the injury to these vessels.
And
so
how
this
do
is very
you
important.
manage it? How would you manage it? Say this
Once
was...
it has occurred, the usual principles are the pressure, patience, and then if you are not able to manage, then you have to dissect those vessels and sometimes ligate or clip. But usually with the pressure and patience, you will be able to manage the 90% of the sites. So you have to give the pressure for exactly for 5 minutes at least, maybe even more.
So what
And
happened?
more,
It was the inferior epigastric. Do you think that is to get controlled by pressure?
if it is inferior epigastric, you can take sutures and
Yes,
just
so you can take a U stitch and you have to do this. So this is very important.
figure of 8 sutures are usually good enough.
Yes, so this is also, this is also a technique which can be done where you can transluminate before fixing the tackers and mark the vessels. So you have marked the vessels, so you don't put the tackers there. So this is another technique which can be used. So Tarun, this is for you. So if there is a recurrence after laparoscopic surgery, so this is recurrent infraumbilical hernia, 6 centimeter defect. 9 years ago, there was a IPOM for post-appendicectomy. What would you do? Would you do open or would you do laparoscopic?
Sir, I would consult the patient for both, and most of the time, because we are able to manage it laparoscopically, we will try to do either a IPOM plus or do a ETP TAR approach and repair the hernia with the mesh.
Yes, so you can do both ways, but what are your challenges? See, if you do open hernia, you go through a virgin plane. So your task becomes easier because that plane, laparoscopic plane, has already been violated. So open hernia becomes much easier, but laparoscopy is much more difficult. What are the challenges you have in laparoscopy?
So the most important challenge in this would be the adhesiolysis, which we have to do to separate the bowel, which most of the time will be there with the mesh, and separate the adhesion. The other challenge would be to close this defect also, because it's a large defect, 6 centimeters. So these two challenges would be there, which will be, if you are doing it laparoscopically and you have been trained well laparoscopically, you will be able to do it.
So that is very, very important, that unless until you are very confident, you should not take over this. Yes. So Dr. Narayan,
yes,
this is for you, male, 31 years, obstructed supraumbilical hernia. The patient had a history of IPOM plus for epigastric hernia 1 year, 9 months ago. And then we went in. And you see, we find a bit of momentum has gone through. And you can see this mesh is there. And this is at the edge of the mesh.
yes,
Just a small hole. So what do you think is the
yes.
cause of this hernia?
I mean, improper placement or fixation of the mesh was not proper.
Yes.
In the
So this is
previous
basically suture hernia.
Yes.
So normally we put a suture at the end. So when you tighten the suture, you see, then it causes suture hernia, which is very, very rare when you take too much of tissue. So to prevent this, your transfixation suture should not be tied very tightly, and you should take only 3 millimeter of tissue. But in this case, since we saw some fluid, so we are not putting in a mesh again, we are just putting a suture repair. So Satish, this is for you. 56 years, IPOM for primary umbilical hernia, recurrence on the fourth postoperative. So Satish, can you see this video? Are you there?
Yes, I am there.
So why do you think this recurrence happened? You can see this video. Fourth recurrence, very uncommon.
I think the mesh was not properly fixed.
Yes. So
You
we
can
don't
see
see
the
transfixation sutures.
it's a floating mesh, I think.
Yes. And secondly, you can see the mesh is also upside down. You see,
Oh, I did not see that. It's very
yes.
So
So one has to be very, very careful. So it is very important that fixation is so important. So you might have a recurrence immediately after if your fixation is not been proper. So this is what went wrong. So Dr. Nirmal,
yes,
this is 48-year-old female, IPOM 18 months ago. And she comes up with, this is abdominal sinus, she comes for 2 months. And we do a CT scan and then we found a mesh collection. So what would you do to the mesh? Would you try conservative treatment or you would go directly for removal of the mesh?
I feel that once a sinus has formed, so the best option will be to open and remove the mesh.
Yes.
Once the sinus has formed,
yes,
it means
any
that,
of the panelists would differ, Dr. Tarun or Dr. Midda or Dr. Bakla, any one of you all would differ? Dr. Chauhan?
I would like to give a trial with the curettage and antibiotic guided antibiotic therapy for some days before I go on for an explantation.
Yes, yes. So both things are there. So there is, yes, Tarun, yes.
Yeah, other thing is like because anyhow after removal of mesh you're not putting in a mesh. If you do it open, then you have gone you have lost that virgin plane which you might place the mesh later on. So it might be not a bad option if you can do it laparoscopically and later on repair the hernia when it recurs with open.
Yes. So I agree with you, Tarun, that laparoscopy, if you can do it, is better. So you can preserve the plane, or if there is a recurrence, you can again do it. And as Dr. Chavan was saying, that there is always a role for conservative, and if it fails, then we go for the removal of the mesh. So we can. It is nothing wrong if we can try a bit of conservative for 2 or 3 weeks. Most probably it will fail. As Dr. Nirmal said, there is a sinus. So we can curettage, send the material for biopsy and cultures and see, and that can also be done. So this is sinus. So these are the things we do to prevent mesh infection. Always used autoclaved instruments. And this should be the first case on list because all of us, in private practice, we are jumping from one nursing to home to the another. So you use it as the first case on the list, change gloves before handling the mesh, prevent mesh to come in contact with the skin. So Satish, this is for you. Post CABG incisional hernia, how do you fix the mesh in the upper part? So
here since we are close,
diaphragm is there, no?
Yeah, diaphragm is there, so we cannot use the tackers.
So you put it by a suture. You put it by a suture.
Sutures and then.
Yes. And if you have a suprapubic hernia, Satish, because see, this is a suprapubic hernia. So how do you fix the mesh in the lower part? Because you will not get enough margin.
Here we will do something like tap. What we do?
Yes.
We'll raise a flap or put in the mesh. If not possible completely, at least most of the mesh
So you can raise a flap, so the bladder also goes down, and you have the symphysis pubis to tack it. So Dr. Chavan, this is for you.
Sir, how?
Male, 54 years old, obstructed right inguinal hernia comes to you. You see early signal. You put the patient on GA, and there is a spontaneous reduction. What would you do? Would you carry with the hernia repair, or would you like to see the bowel?
No, the bowel has to be always seen because there is a possibility of reduction in mass taking place and the strangulation may continue.
So what would you do? Would you do laparoscopy?
Usually you should be able to see, if you're doing an open repair, you should be able to see this, the gut which has gone in. But if you cannot, then you have to do a laparoscopy and be very sure that the gut which has gone in is viable and is not strangulated.
Yes. So this is very important, that you need to see the bowel. The message we want to give is that if there is a reduction under anesthesia, please see the bowel, whether by laparoscopy or while doing the hernia surgery you would do. So Dr. Chavan, in this case, you can see the bowel is congested, pregangrenous. What would you do? What type of repair would you do in this?
No, I wouldn't be using any mesh in these kind of cases. And standard, if it's inguinal hernia, a standard Bassini's would be, a modified Bassini would be the repair I would be doing it, because there's a risk of the mesh getting infected.
Yes, I agree with you, Dr. Chavan, but do some of the people, any of the panelists, do they have a different view? Tarun?
Agreed, I think.
If it is just strangulated and bowel vascularity is there and not too toxic fluid is there, then we can place mesh. Otherwise, it's better not to place.
Yeah. So Tarun, this is for you.
Sir, we will have to hurry it up, sir.
How much time do you give us, Dr. Pandey?
Sir, 1 hour, sir. It was.
No, how much time more you give? 5 minutes more?
5 minutes more, yes, sir. Okay,
yeah,
sir.
Good. 5 minutes, good enough. Recurrent groin hernia, Tarun, right?
Yes, sir.
Patient had an open right stopa. And see what has happened. The surgeon, senior surgeon, went in laparoscopically. I think it's a very wrong choice of case. And you see he's doing it. And he has gone into the major vessel. So what would you do, Tarun, in this case?
Sir, we would like to see if it's inferior. Sometimes it can be just be inferior epigastric also,
no, it's
but
not
it looks more.
It
looks more now. Initially, it was not looking. So, most important is compression and call for help, and have two sections ready or one section ready. Compression and call for help.
Call for help, compression, convert.
Yeah.
See, why did it happen? Because it was a wrong choice of case. It was the ego of the surgeon which was there. And Satish, this is for you. You can see this. So what do you think this is bleeding, Satish? Tarun has given the answer in this last one.
This is a major blood vessel, I think.
Yes, it's an inferior epigastric. So you hold the artery, you might do a bipolar or you suture it. Now, Dr. Nirmal, this is for you.
Yes.
We're doing a tap repair, and you can see it's again a senior surgeon, very confident. He has not followed the principles, and so you can see the Foley's catheter, right?
Yes.
So what would you do with the bladder injury, Dr. Nirmal?
Bladder injury has to be repaired instantaneously.
What would you do with the hernia?
I would personally differ with the further hernia procedure.
I think so, because some
I will repair the bladder, put the Foley's and come out.
Yes, put a Foley's and come out. And the cause of this was the surgeon went medial to the medial umbilical ligament. You should never go medial to the medial umbilical ligament. And I think this is the last one, Dr. Pandey. We will wind up after this. Tarun, you can see these X-rays. These are the tackers. they're all where, what is wrong with these stackers?
So
Patient
they
is
should not be below the pubic tract or the anterior superior iliac spine and the line joining the pubic tubercle. They
so
should
one
be
has to
above
be very,
that.
very careful about this. And how do
Yeah.
you treat this?
Yeah. So basically, this is a very complex situation. Most of the time, you will require the neurectomy for these. If you do not do neurectomy, this pain will not get resolved now.
So thank you very much. I think we still have a lot of this, but for want of time, we would just say that anyone who has never made a mistake has never tried anything new. This was said by Sir Albert Einstein. What you need is a balanced approach to hernia. It all depends on your experience, your infrastructure, or your training. So it's not necessarily that you have to do all hernias laparoscopically. Still, 95% of the hernias are done by open surgery. So it's all right, but you can always learn laparoscopic surgery. So you have to have a balance. Thank you very much.
Can
Thank
you
you
have,
to the panelists.
can I have one chance?
Yes, Dr. Jha.
Yes.
Yes. Good morning to all panelists.
Thank
you. Good morning,
all
sir.
funny. I enjoyed discussion, Dr. Satish.
Yes.
Because I'm in the teaching institution, so I have some basic questions. First
Yes,
is,
sir.
what about cord division instead of orchidectomy? Sometimes you divide the cord only and preserve the testes in case of hernia operation.
We discussed that uh, we should take it as a
Is it
last.
in practice? Is it in practice or not? That I want to know.
Nowadays, usually we should try to avoid it. But if it
Okay.
is in desperable condition, then only we should go for it.
No, that is different. Second point is large ventral hernia. We sometimes go for abdominal binder practice for certain days and week, and some of the patients improve. Then we go for surgery. What is the opinion of the panelists?
Means pre-operative optimization is a must. That
That is by
includes
abdominal binder. Dr.
means,
Narayan, good morning.
Morning, sir. I don't feel, I mean, if it is reducible, then it is fine. Whatever point is reduced, put a binder and can attempt it for days and days and weeks.
Yes.
But if it is not reducible, then
Yes.
it is no need. But if it is reducible, patient must be directed to reduce herself and put a binder. That will help.
Very large hernia. Very large one.
non-reducible
Loss
may
of
be
domain.
sometimes harmful.
Yes.
If it is non-reducible, sometimes you may be compressing the bowel loops and
Yes, and that way we can it can lead to gangrene or something. But if it is reducible, it is well enough.
Now, last one question. What is the learning curve for laparoscopic surgery? What is the learning curve? How many cases? How many hours? How many days?
at least you should have an observation for about a month or so, and then at least 25 to 30 cases before you
To be
get
done.
the yes.
So number of cases 25, 30. An observation, how many days?
At least few months, 2 to 3 months in a good
Where? In low
center.
volume center, high volume center?
High volume, not low volume centers.
So that is important because every young surgeon would be laparoscopic surgeon, and Dr. Ramesh showed so many videos where we have committed mistake and we learn by mistake. Okay, thank you very much.
Thank you.
Thank you very much.
Dr. Ramesh.
Okay.
Thank you to Dr. Ramesh, Dr. Satish. Thank you very much.
Thank you, Dr. Ramesh. Thank you, the
Thank you,
organizers, for giving us a chance.
Dr. Chauhan, thank you. And
Thank
Dr.
you.
Bakla, thank you very much to the whole team.
Thank you, sir.
Thank you.
So much for
Thank you.
nice discussion.
Okay, sir.
Thanks
Thank you
to
very
all
much.
the panelists and the moderators. Kindly accept the
Thank you, Sushil. Thank you, Sushil.
Dr. Bakle sir, NP Narayan sir, SS Chauhan sir. Thank you so much, sir.
Thank you.
Thank you, Dr. Pandey.
Please join Hall A for the inauguration ceremony.
Thank you, sir. We pray for the health and wisdom of all of us. I now request you to say a few words.
I think I'm audible.
You're logged in from
Just come back to the.
You're logged in from 2 devices. That's why.
Yeah, that's why I'm switching off the other one. It doesn't take up the. Yeah, okay. Now I think you are audible now.
Yes. Yes.
Yes. Yeah, I think I switched off the other one. Sorry. At the outset, let me thank the Jharkhand chapter for having given me this opportunity to be part of this wonderful occasion, their annual meet, Jasicon 2020. Dr. Sunil, I am really thankful to you for having given. This was a real good opportunity for me to meet all of you and be a part of this wonderful meeting. And from morning, I'm seeing the flawless way the meeting is being conducted. So many stalwarts exchanging views. Very nice topic, especially the debate was really enlightening, and I could learn a lot of things from that, as well as you said, the chairman said we are learning through this debates and symposia. What is important to see here is that ASI and its chapters have become so fast adopted to the new changes which has evolved because of the pandemic. We have become virtual in all the meetings. We have become so versatile, and we have adopted to the newer changing modalities in the learning and conducting of meetings. I think this change is bound to continue for a time to come. I don't know how long, but we have adopted to it. We may improve, keeping aside some of the glitches, and improve and see how nicely we are continuing to conduct these meetings. So that is what I learned from today's meeting. And I take this opportunity to thank all the members of ASI who have really given me a big mandate, and the numbers really doesn't matter. But what makes me feel is that it makes me more responsible and committed to the cause of ASI. With stalwarts who have been in the past contributed to the ASI, starting from Shiva Mishra, I have been seeing Santosh, and then later on Arvind and Abhay going to continue, and Raghu having done such a wonderful job. It's going to be a tough job for me in future as I look forward to match these stalwarts in their performance. And I promise with my best ability, I will continue to contribute to the best of ASI without turning any stone. And I will definitely stand up to, try hard to stand up to all your expectations. And lastly, to the Jharkhand chapter, what I see is though the number of members there are small, but what I came to know going through this elections process when I was campaigning, a lot of members of who are practicing in Jharkhand state, they have addresses from other states. The reason what I felt was there are not many medical colleges producing postgraduate students. All the practicing surgeons, either during their postgraduate studies or during the training, they have become members of ASI in different states. So I think the state chapter should consider updating their addresses, so your Jharkhand numbers go up. So that is what I saw as an observation, just as a small suggestion, Sunil, and the people at helm of it can take it up, and we can at ASI can contribute to whatever and people of India definitely can see this meeting today. Congratulations to all of you again, and thanks again for giving this opportunity. Sunil and your team have a wonderful job. Continue doing this good job, and thank you for again for giving me this opportunity. be part of this meeting. Thank you.
Thank you very much, sir, for your kind words. And now it is indeed my proud privilege to welcome our chief guest, Dr. P. Raghuram, the National ASI President, to this gala meeting. He needs no introduction, but I just remind us of his few achievements. He is a Padma Shri awardee, a Dr. B.C. Roy awardee, and he is at present the president of the Association of Surgeons of India. He is the director and consultant surgeon at KIMS Usha Lakshmi Center for Breast Diseases. He was conferred with Edward Kennedy Memorial Award for outstanding contribution to breast oncology in South Asia. He conceived, designed, and established South Asia's first purpose-built freestanding comprehensive center for breast health in Hyderabad in 2007. He has been the overseas coordinator of in 2005 to 2008, executive committee member and editorial secretary of IASO. Sir, we welcome you to our gathering. And lamplight brings brightness and dispels darkness, helping us to see clearly. By lighting the lamp, we bow down to knowledge, which is the greatest forms of wealth. And for this, I request Dr. P. Raghuram, our chief guest, to do the digital lamp lighting by giving us a namaste sign. Sir. Dr. P. Raghuram, sir. Sir, are you there? Yes, sir.
Holding hands is the best form of expressing gratitude.
Thank you, sir, for lighting the lamp. As we move ahead with our proceedings, I invite our GC member, Dr. J.K. Chaudhary, who is well known for his philanthropic activities, recognized also by ASI, to say a few words. Dr. J.K. Chaudhary, sir.
Our chief guest, audible?
Yes, please go ahead.
Chief guest, Dr. P. Raghuram, President ASI, guest of honor, Dr. Aved Alvi, Vice President ASI, special guest, Dr. G. Siddesh, Vice President-elect ASI. Congratulations, sir. Patron and past President ASI, Dr. R.P. Srivastava, and mentor of our chapter. Our chapter chairman, Dr. Uday Srivastava, Secretary, Dr. Mohammed Azad, organizing chairman, Jasicon 2020, Dr. Sunil Kumar, Secretary, Dr. Arunima Verma, our guest speakers, my seniors, colleagues, and member delegates. I welcome you all from the holy city of Devghar, Baba Vaidnath. I am delighted that our chapter in the pandemic era of COVID, has done tremendous work. My thanks to all the community, and especially to me. Thank you all. Long life ASI.
Thank you very much, sir, for your kind words. And now request our dynamic secretary, Dr. Mohammed Azad, to present the secretary report. Dr. Azad? Yes, please present your secretary report.
Johar Jharkhand. Actually, secretary report has been circulated on WhatsApp and to every member of ASI Jharkhand. It is there. It's a great occasion for ASI Jharkhand to host Jasicon 2020 on virtual platform. On this occasion, I welcome all seniors, colleagues, and friends who are attending this conference. Organizing Secretary Dr. Arunima and Organizing Chairman Dr. Sunil has done tremendous work to make this conference a grand success. On behalf of ASI Jharkhand chapter, I do hereby extend heartfelt thanks to all who are attending this conference. Thanks, ASI. Thank you.
Thank you very much. And now request our chairman, Dr. Uday Srivastava, for his chairman address. Dr. Uday, please unmute yourself. Please unmute yourself.
Dr. Uday, you need to unmute yourself. Please unmute yourself, Dr. Uday. We are not listening anything.
Dr. Sunil, I think he's already unmuted. He should unplug his device that he's using, because I think if he unplugs, he will be heard.
Please unplug your headphones from the computer, Dr. Uday. Okay, sir, we'll have your address after a while. Please log in again. Please log in again. We'll have your address after that. We would move ahead. And as we move ahead, it's as I'm the master of ceremony, I'm just asked for the formal installation as the incoming chairman, which has to be done by our patron. RP sir, are you there? Please say a few words, and you have to do the installation.
Yes, it is a great moment in life, sitting in the corner of Jharkhand, in the confines, and still having friends like incoming vice presidents from down south. Here are the incoming president of the ASI, our reigning champion president of this year, Dr. Raghu, and all my Jharkhand friends from overseas and all over the country to this meeting. This meeting has set a milestone in the history of Jharkhand. As 20 years back, Jharkhand chapter came to be 2020. It's the perfect 2020. The caller was done by no other in 2 months by Sunil Aruna and your team. When you were given this opportunity and challenge that can you host this virtual conference, we were a little skeptical, but we were very, very firm on the strengths you have. And you have proven, you have raised the bar. It will be difficult to follow for anybody else incoming. I'm very happy that the challenge is falling on the shoulder of this young girl who is in the frame. Please bring me also occasionally into the frame so that I can be viewed by others. So this girl, she has proven here,
And now the challenge has fallen on her head to be the incoming chairperson of this chapter. And this is the first time that we are giving it to your gender, and I'm 100% sure that you will give it a motherly and sisterly concern. You sort out every issue and you'll come out with fine colors. So may I request our chief guest and all others on the dais, virtual dais, to clap for Arunima, who is being told by the incoming chairperson of the Jharkhand State Chapter. Having said that, can I have a minute more?
Yes, sir.
Is this my time or my time is?
Yes,
So the history was like that. 20 years back, we started. We were not being believed by so many. But I'm very happy that Raghu has visited Jharkhand. Incoming president has also visited Jharkhand once, and it is high time that he is going to come next year to us, not actually in real and physically.
Surely, sir.
Since you have probably not come here, if I am remembering the history, you have not come here. So we are saying a Johar, and we are welcoming you to be a part of us physically. Virtually, you are a part of us. And incoming year of ASI will see all the humble, dynamic, and very, very straightforward approach in leadership who will show us the path the ASI has not seen in the past. I wish all the success to the organizing chairman. Sunil he has done it with impeccable humility. Arunima has followed his suit, and the team of organizing committee, as well as the youngsters chosen by this team from all, right from the far east, northeast, then the center of Jharkhand, and then the west of Jharkhand. You people have done a wonderful job. In between came Sumega, who chipped in and did an excellent job. And I'm really proud of every one of you at this moment. Thank you very much. Long live ASI, long live Jharkhand chapter, and long live our motto to excel. Give us the challenge. We will definitely accept the challenge, and we will try to overcome it like we have shown in this pandemic by doing this excellent virtual conference.
Thank you very much, sir, for those words, and I am sure you would continue to guide us throughout as you have been guiding us. Thank you very much. We have with us Dr. Abhay Dalvi, the National ASI Vice President, and having interacted with him closely on few occasions, I realize how every occasion is significant by understanding every minute detail and giving it the due importance. He is a well-known national and international figure and is Professor of Surgery at GS Medical College, Mumbai, and Professor at Surgery King Edward VII Memorial Hospital, Mumbai, and is a consultant surgical gastroenterologist at Hospital, Mumbai. So we welcome you to this occasion. And before we ask you to say a few words, we have to commemorate this first ever virtual conference of ASI Jharkhand chapter. We have come up with an e-souvenir. And we want you to release this e-souvenir. And since it's a virtual one, again, we would go ahead. You can give us a thumbs up sign. We can release this e-souvenir then. And sir, I would just open the e-souvenir. And this is the e-souvenir, which as has been released now, will be available for all on the ASI Jharkhand website to download. Just take 1 minute. Just release it. Yes, sir. And I just scroll through to show that this is an e-souvenir and this is PDF format which can be downloaded.
Change the screen now. PDF.
Okay, just second. Can you see the screen now?
Yes, yes. Please come on the screen.
So this is the e-souvenir, sir, that you have released. And this is the content. I'll just scroll through just to show what it is. I thank all the guest faculty who have given in guest articles for this e-souvenir. And then after the guest articles, we have got all the abstracts that we received, and we had an overwhelming response. We had almost 80 paper presentations, including poster and free paper and best award session papers, and all have been compiled in this e-souvenir. And at the end of the e-souvenir, it's a gratitude from the organizing team for this kind of participation. And I request all members, whoever is interested, to just download this PDF and look at it. I'm not preparing any kind of, as we are going to the green world, we do not want any paper written on this. It is going to be e-souvenir, and this is our gratitude at the end of it. This was our souvenir that we released. And before we move ahead, I just want to hand over this certificate of appreciation to the organizing team of Jasicon 2019 from Jasicon 2020. And now I want Dr. Abhay Dalvi to say a few words and address the gathering.
Yeah, good afternoon. Let me congratulate Dr. Sunil Kumar and Arunima to have staged a wonderful state chapter conference here. I have attended yesterday, especially Arunima's lecture, which I was quite impressed. And today itself, since morning, I have been attending this. It has been really, I don't know what to say here. Such good scientific deliberations. The debate, last one was something which was really an eye-opener. And let me thank you for asking me to release this e-souvenir. I wish the state chapter all the best. And Arunima, you as incoming president, I'm sure you will reach more heights in the next year to come as I take over the presidency of ASI. Thank you so much, and let the proceedings go ahead.
Thank you very much for those motivating words, sir. And we have the delight of having with us the chief guest who has been witnessing the performance of a chapter. And now I request Dr. P. Raghuram to address the ASI Jharkhand chapter.
Thank you, Dr. Arunima. May I share the screen, please?
Yes, sir. I'll stop sharing my screen. You can go ahead and share your screen. Yes, sir. Please share your screen.
Right. Good afternoon, everyone. On behalf of the National Executive Committee, warm greetings from our headquarters. It is such a great pleasure to have the incoming president and the vice president elect on the same podium. It's the very first time Siddesh is on this podium, and all credit to Jharkhand, starting from there onwards. And I always think this is part and parcel of my life. This is the part and parcel of my life when I wake up in the morning and before I go to bed. And on this occasion, yes, gratitude is due to the visionary chairman of this Congress and also to the dynamic secretary. I'm mean, you know, attention to detail is something that everybody, it's not that everybody's cup of tea. And your attention to detail speaks a lot, not only during this conference, not only during the previous conference that was held about a month ago relating to the ASI, but throughout, you know, you have demonstrated extraordinary commitment to the association, and the association will undoubtedly benefit from your experience. And of course, I must mention here that Dr. Jugal Kishore Chaudhary, an esteemed member of our National Executive Committee, has been chosen by virtue of merit as the Social Service Award recipient of 2020. Many, many congratulations to you. We have taken great care. ASI believes in creative leadership and accountable governance and no nonsense approach. We don't believe in doing any favors to anybody, regardless whether he or she is my friend, my colleague. We have always, throughout this year, Dr. Abed Alvi is here, therefore I can say with confidence there are several things that I have discussed with him, and we believe that we will ensure creativity, and I have put my hand on my heart and kept everybody aside, my friendships, my contacts, my requests, pressures, and then delivered justice. And all our awards this year speaks volumes about that. Dr. Uday Srivastava, our chairman of the Jharkhand chapter, Dr. Mohammad Azad, you know, you have done great work for the chapter. So my year began last year, December, and as I said, my mantra has been from day one, creative leadership and accountable governance. This is editorial published in the February issue, which has the highest number of views that an editorial has been accessed ever since ISS existence. Very grateful for that. My presidential term can be easily classified into 3 phases: the first 3 months, then March to June, and then June onwards. So we have at any given point 15,000 trainees. And so my presidential planning start off with this by introducing a number of skills courses for our trainees, some of which were held for the very first time in our association. Between January and March, we did close to 15 courses across the country. And then the second phase began. I was put into the deep end. Never ever expected that I would have to get into this. And the very first interaction during this pandemic started off with the video interaction with the Prime Minister. This is a video that went viral, not only amongst the medical fraternity, but also outside the fraternity, not only in this country, but elsewhere as well, because I had many calls from friends who are in the US, UK, Australia, and many other places. And some of the points that I had highlighted were was actioned by the Prime Minister on the very, very next day. And I take great privilege to share this slide that, we as an association, you as a chapter, and everybody in the association have listened to this occasion and have mounted a never before witnessed philanthropic exercise in the 82 years history of our association. And instead of just giving away the PPEs, which were so much scarcity during the months of March, April, May, and June, there were only 8 companies that were making the PPEs. Now, India makes the largest number of PPEs, but at that time, I was spending close to 3 hours every day begging the supplier to pay these things, and used all my resources, all my contacts, to put pressure on him so that these PPEs are handed over to our chairman and secretaries of various state chapters so that they can reach out to the grassroots healthcare workers. These are some of the images. Not only this, we have also partnered with Amway India and have provided 4,000 hand sanitizers to 56 COVID-designated hospitals across the country. This exercise would not have happened without the active intervention, active help from the chairman and secretaries of the chapter. And once again, folded hands, very grateful to Jharkhand for taking a lead in helping ASI to deliver its promise of philanthropy. And somewhere along the middle of this pandemic, we also came out with guidelines which were published as an editorial in the June issue, because at that time there was no clarity what we should be doing from the time the surgeon leaves his home, what he should do in the hospital, what he should not do in the hospital, what he should do after he comes back. This has received a lot of appreciation from our members. And pleasantly surprised, I was pulled into the front line of the national media, print and electronic, where I was invited to give my comments. And as I have done in the ASI, I have spoken my mind fearlessly, boldly, representing your views, representing the association's views, not only on aspects relating to deal with the medical aspects relating to surgery, but so many things I have learned. I have improved my common sense, and my children are also surprised at me, at the way I have delivered on national television. Also invited to contribute editorials and invited articles in many print media. And finally, the third phase began in June with modifying, adjusting to the new normal. We started off with conducting the online National Skills Enhancement Program and just finished the RRC, where the chief architect was Santosh John Abraham, all along, very ably assisted by our incoming President, Dr. Abe Dalvi, nurturing this program. And as I said yesterday in the concluding session, as all good things have to come to an end, but RRC is so good that it will not come to an end. It is our flagship initiative. It is our main program, and this will get better as we progress to next year and year after next under Sindesh leadership in 2022 as well. And finally, before I conclude, I would like to request all of you in Jharkhand, all of you watching this program, to participate in our flagship annual conference, the 80th annual conference of ASI, being held in the virtual platform. It is my wish, it is my desire, it is my dream that this virtual conference should be the biggest ever and most successful virtual conference that any medical congress has happened in this country so far. So I request all of you, and through your chairman, through your secretary, I request all of you to be registered and participate in this your conference, and it is with your participation that it will be successful. And finally, I'd like to pay tribute to the organizers. To organize an on-site meeting takes some effort, but to transform this on-site meeting and transpolate this to conduct a virtual conference takes some vision, courage, determination, and tremendous hard work. Once again, very grateful to you for inviting me to participate in this historic Jharkhand chapter annual conference. Namaskaram. You're muted, Dr. Arunima.
Yes, sir. Thank you, sir, for those inspirational and heartening words. And as we come to the end of this inaugural ceremony, because Dr. Uday, have you been able to sort out your mic?
Verify. Am I audible?
Yes, sir. So just 1 second. I want you to present this e-token. So Dr. Uday, please present this e-token to Jasicon 2019 on behalf of Jasicon 2020. Thank you very much. You want to say a few words?
Let us proceed. Proceed.
So, as we come to the end of this ceremony,
No,
I take this opportunity.
Okay, sir. Thank you, Dr. It is my privilege to welcome our President, Dr. Ram, our coming President, Dr. Abe Dalvi, for 2022. We are very much thankful to our platform, which stations always need for us and us to do whatever we do in our state, and there to scrutinize our functions. And I'm very much thankful to Dr. Sunil and for this good academic session, the Jasicon 2020. Thank you.
Thank you very much, Dr. Uday. And now I would like to take this opportunity to thank our eminent guests for sparing their valuable time. Dr. P. Raghuram, Dr. Abhay Dalvi, Dr. G. Siddesh, and all the national and international faculty who joined us for this conference and have given us immense enthusiasm. I also thank each member of the organizing committee, Dr. Sunil, our organizing chairman in particular, for all his patience and leadership from the front. I thank the ASI Jharkhand pillars, Dr. R.P. Srivastava, for being a guiding light, office bearers of ASI Jharkhand chapter, especially Dr. Uday and Dr. Azad, for their support. It is indeed a very heartening moment for me to thank the young team who took over as session in charges to make this conference so seamless by putting in days of hard work. Satvir, Sumegha, Sumit, and Sushil, all of you were exemplary. I thank each presenter, chairperson, judge, and delegate for coming to this platform and contributing in the success of this conference. Last but not the least, I thank our website team, Anand, Sachin, and Sabha, for the excellent and flawless e-platform created and managed with months of hard work. At the end, please excuse us if there were any lapses or inconvenience during the conference. And now, as we come to the end, I ask everybody to rise up for the national anthem. And you can switch off your cameras if you want. Please rise up for the national anthem.
जनगणमन अधिनायक जय हे हिमाचल जनगण
Thank you very much, everyone. We will now continue with our scientific session, and I would just remind everyone that the e-souvenir is now available on the website to be viewed, as well as the e-posters are available in the e-poster arenas. Please view the e-posters and the e-souvenir. Now we move ahead with a scientific program. I would want Satvir to take over, Sumegha to take over. Sumegha, please take over.
Yes, thank you, ma'am. So we move on with the next program, and that is Dr. Rambali Sinha oration. I would like to welcome our chairpersons for this oration, Dr. Sunil Kumar, GC member and editorial board member of JMS, and presently the organizing chairman of this conference, Dr. Diptinder Sarkar, immediate past president ABSI and honorary secretary Asian Association of Mastology. We all know him very well, and not delaying much time, I request Dr. Sunil sir to invite and introduce Dr. P. Raghuram, who is already with us.
Okay, I invite Dr. P. Raghuram, who is a well-known national and international figure, for this oration, prestigious oration of Dr. Rambali Sinha. Sumekha, do we have the introduction of Dr. Ambali Sinha, which?
Yes, sir.
Okay.
Dr. Raghu is supposed to read that
Yeah,
oration, sir.
exactly, yeah. So inviting Dr. Raghu for this prestigious oration. Back to you, Raghu.
Can I share my screen, please?
Yes, you have the Dr. Ambali Sinha, or yeah.
Good morning, good afternoon, once again. On behalf of the Association of Surgeons of India, welcome to you once again. I have a pleasant duty here, and it is such a pleasure to know about Dr. Rambali Sinha, a distinguished and a legendary surgeon par excellence, having graduated in medicine and after completing his MS, he went on to pursue higher surgical training in the UK, and it rings a bell because I too went and did my FRCS in the UK from multiple colleges, and it's so nice that he secured his FRCS from London, Glasgow, and Edinburgh within 15 months of going to the United Kingdom. And then he came back and joined the Rajendra Medical College and trained a number of surgeons. He further established a nursing home in 1974, which is named after his mother, Keshri Nursing Home, which has really championed really modern healthcare in many ways, because it became a very popular center of excellence, and he performed over 50,000 surgeries in this nursing home, and really got name and fame to Jharkhand because of this hospital. In 81, he became a fellow of the International College of Surgeons, and Dr. Rambali Sinha was known to be a distinguished academician, and he was associated with a number of academic activities, including the ASI and the IMA. I was so delighted to know that he was very actively championing the social activities. Social service was in his heart and soul, and therefore he contributed immensely to social service. And I was also equally are aware about. I think it's very important as doctors that there is a lot of life outside medicine as well. It is important, and it is so Shanti Devi ji, Dr. Anita Singh, daughter-in-law practicing at Ranchi, and Dr. Renu Chaudhary, doctor practicing in Jamshedpur. Many surgeons were trained by Dr. Rambali Sinha and are indebted to him. So it is indeed a God-given opportunity and a distinct pleasure to deliver an oration which has been instituted in his name. Thank you very much, Jharkhand chapter. So I go on, and I would like to just yeah, I'm just trying. Can you see the slides?
No, no, no.
Raghu, please share your
You
screen.
need to share here.
Is this okay?
No, it's
No.
not coming, Raghu.
Is it not? I think
No.
the share has gone off.
Anand, did
Okay,
you?
I'll come back again.
Yeah, it's coming. Yeah, it has come, Raghu.
Yes? Is it there?
Yeah, it's
Yeah,
there.
Yeah,
Okay.
yeah.
So I'd like to begin off by saying it may sound a little blasé, but it takes a lot of courage to show your dreams to someone else. And therefore, I did have that courage. Even before relocating to India, I did share my dreams to everyone in this country. And I am here speaking to you because of my parents. Without them, I am a completely nobody, and I would have been a nobody. As they say, everything begins with a story. My story began when my mother was diagnosed with breast cancer in 2002. When I was working in the UK, I realized that in our country, lack of awareness and absence of an organized screening program is the reason why majority of women present with advanced breast cancer, and every 10 minutes someone succumbs to breast cancer. This is a lady from whether this can be replicated in a state like Jharkhand. The foundation that was established in 2007 bears my mother's name, Usha Lakshmi. And the foundation had three phases. The first phase was priming the community and empowering the community. Because there's no point in my coming back from UK and say I'm foreign returned. Nobody's going to listen to me. I have to integrate into the community to be able to empower them. That is what we did for the first 5 years. The second 5 years implemented a population-based screening program. And in the third 5 years, which we are in now, outreach programs being done through a number of innovative initiatives. So what did we do in the first phase? The first phase focused on breast cancer advocacy. In India, breast cancer is a closet issue. It is a issue that is hushed up. And that is why more than 60% present in the advanced stages. And I knew very well before relocating that I had to disrupt this attitude. And so this foundation principal goals were to create awareness, to reach out to the community and support survivors with the slogan empowering people, impacting lives. Awareness, awareness, and awareness is what I focused on. When I came back and started going to various non-medical associations with a view to creating awareness, there were only 5, sometimes 2 people attending the meeting. Today, I can tell you that if the foundation goes to create an awareness, there is a hall full of people. There is no space to sit. People are even standing. That is the kind of awareness that we have created over the years. One of the first things I did was to collaborate with Breast Cancer Care UK, which is UK's largest breast cancer charity, which is the only organization that they have associated outside the UK, was with our foundation, where we have printed and published and distributed more than 100,000 information booklets on every aspect of breast health, explained in simple, easy to understand language, so that people are better informed, better prepared, and feel in control at every stage of their treatment. The Pink Ribbon campaign by a celebrity. Those of you who are in the Bonnier era will recognize this lady, Marcia Barrett. She asked for first class. We've had people from all walks of life. Today, I can tell you that when September comes, people call me, celebrities call me. Can we come and flag off the walk? Can we come and participate in the walk? This is the kind of movement that we have brought about in Telangana. This is the Buckingham Palace in pink. This is the Tower of London in pink. This is the White House in pink. And similarly, several monuments, not just one monument, several historic monuments and buildings, ladies and gentlemen, turn pink for the 10th consecutive year. And so impressed was this Paint the City Pink campaign that the Honorable Governor, the First Lady of our state, approached the foundation and said, we will illuminate Raj Bhavan in pink. This has never ever happened before in the history of our country. And so the Raj Bhavan also turned pink on the 31st of October. So has the breast cancer advocacy over a 13-year period created an impact? Yes, it has made. In urban India, in urban Telangana, in urban parts of Andhra Pradesh. But what about screening? And when I speak about screening, I'm not going to speak about the opportunistic screening. I'm going to touch only about the population-based screening. And I do not want to waste too much time speaking about the evidence relating to screening, because we all know that screening mammogram saves lives. There is no doubt at all. Several randomized controlled trials have demonstrated this fact, and that it prevents death from advanced breast cancer by detecting breast cancer in the early stages. So opportunistic screening is what we launched in October, but I will not go through this because I'm going to skip all of these slides to take you back to the screening, population-based screening. So in this second phase, we launched the population-based breast cancer screening because all of us are aware 70% of our population live in rural India. And what applies in urban India doesn't apply in rural India. And therefore, to implement a population-based screening program needs to modify what you want, modify our way of approach. Is mammography a screening tool? Will it be a screening tool in the population-based setting? The answer is no. Why? Huge costs, huge variation in mammographic reporting. We have very, very few breast radiologists. And the important thing is less than 17% of our population is over the age of 50, where screening mammography is very, very effective. So therefore, breast self-examination is not useful. Clinical breast examination as a screening tool there has been a lot of circumstantial evidence to show that it works because it is simple, it is inexpensive, it helps to downsize the tumor size, and an excellent opportunity to empower people about breast awareness. So as I said to you at the beginning, I utilized the first 5 years of relocating to prime the community, to empower the community. And in 5 years' time, we were so well known that the government of the day took notice of our proposal to the government saying that we want to partner with you. If I had come back in 2007 and said to the government, look, I've come back from the UK, I'm UK returned, I want to bring about a change, nobody would have given me a damn. It is because of the fact that we have demonstrated on the ground the impact. When I had approached the government that I'd like to partner with you, they readily agreed. And we had the chief secretary, the health secretary, the district collector, you name the people in the district, in the Hyderabad region, they were with us when we launched this program where we were training the healthcare workers. This is the Honorable Chief Minister of our state. I presented him with the pink illuminated legislative assembly, something that has never happened. And he was so happy. And this is the chief minister of the neighboring state. Now it was the undivided Andhra Pradesh in 2012 at that time. So what did we do? We produced audiovisual aids and booklets and we printed them. It took me 1 year to make the audiovisual aids. And we trained the healthcare workers to perform clinical breast examination. Women between 35 to 65 years were screened, and if it was normal, they were brought back for further screening. And any abnormality, it was reported to the district health officials, and treatment was provided free of cost. I must confess here that I am working in a private hospital which also treats Arogyasri patients, that is free treatment. I wanted to ensure that this program, hospital where I am working, should not be a beneficiary to this program. So therefore, this hospital was excluded from free treatment because nobody should raise a finger that somebody is doing social service and at the same time is attracting patients. This is a lesson and I want to share this lesson because this is something as a model which also can be implemented in Jharkhand. These are the healthcare workers who are trained in several batches. I personally took my time off to ensure that this training program was supervised. This is a typical village scenario, a community hall where you have a healthcare worker educating people in Telugu. Then you have the video which is being played, and these healthcare workers are so closely connected with these women that they, without hesitation, would allow them to examine them. If I would go to the village, which I tried, and tried to implement this, nobody will listen to me. But a healthcare worker is the nodal person. She takes people into confidence. She doesn't go to the village and say, okay, come, I'm going to do a clinical breast exam. No, she takes them into confidence. She empowers them. She gains their confidence. And then there is no problem. It is half the battle won. I had unrestricted access to the secretariat, the government secretariat, where every week, twice a week, I would be involved in clearing the doubts of the district healthcare team and also from the healthcare workers. And over a 4-year period between 2012 to 2016, over 200,000 women between the ages of 35 to 65 spread across 4,000 villages in Telangana and Andhra Pradesh were screened for early signs of breast cancer. So much was the impact that was made in the Telugu states that I was invited to be part of the technical advisory group set up by the Ministry of Health in 2016. There you see the health secretary, and I had pitched for this program to be implemented pan-India. And I'm very pleased that the clinical breast examination based screening program is now part of the National Health Mission's screening program alongside cervical and oral cancer and is being rolled out across the country. And in 2009, to assist the National Health Mission in Telangana, I submitted once again another proposal for a second round training of healthcare workers. This is the Chief Secretary of the Government of Telangana, and this is the Health Secretary. This is the Director of the National Health Mission who is standing next to me. And we were able to start this training program once again, renewing the training program so that it reaches out to so many people. So we have now entered the third phase. The third phase of the foundation is to utilize innovative initiatives to reach out to the community like never before. So what did we do? Inspired by the Prime Minister's Digital India campaign, conceived, designed and established the world's first mobile app on breast health, which is in 12 commonly spoken languages. This is called ABCs of breast health. This has got information on every conceivable aspect of breast health. It is freely downloadable on App Store and Google Store. No questions are asked. No mobile phone number is taken. Nothing. You just go in, you can download this app. And when I had approached one of India's icons to launch this app, he readily agreed. And I said that we are not paying you anything, sir. You may charge crores of rupees, but for this app, you will do it without taking any money. He called me. He grilled me for a few hours at his home. He understood the nuances and then he launched this, and he has now become the face of this campaign. I don't think you can hear this, but he was so very, very kind and very, very generous. Not resting on this, I had taken the help of my good friend Sindhu, who is an international icon. She and I were conferred the Padma Shri on the same year. And I said that you have to help me with launching artificial intelligence. So with augmented reality, you can reach any part of the country. If you can download that app, I can go to my adopted village sitting in Hyderabad and create a downloads that app and he just switches it on. He will see a life-size image of me or the celebrity with the local background. Here you see me in Kim's hospital. I'm in the hospital today at work. You see my background here in my office. But I can create a background just as the background is in that village. Just I can go into anybody's home, and if they download this app, they can watch me with the background of their home. And therefore, this concept is that the celebrity and the doctor can go there. This is a different presentation altogether. I don't have time to do that. So therefore, I'm just bringing in that concept of life-size augmented reality introduced for the first time in the world for breast cancer awareness. This was launched last year. And just very recently was part of another virtual on-site online initiative reaching out to 725 districts in 29 states in 12 languages. So in conclusion, ladies and gentlemen, the rising incidence and mortality and advanced stage at presentation is certainly a cause for great concern. The breast cancer advocacy over the past decade has certainly disrupted the taboo and has created that much needed awareness about early detection. Screening significantly reduces the risk of advanced disease, and in a country like India, clinical breast examination is an effective population-based screening tool. We must not, all of us sitting in this audience, all of us watching this program virtually, we must not deny our loved ones a screening mammogram every year. Deepavali is coming up. For the men in this audience, for the men watching this, please gift your loved ones, your spouse, your mother, your aunt, your grandmother, your friend, a screening mammogram. Instead of gifting a sari, or in addition to gifting a sari, the men watching this, please gift your loved ones a screening mammogram, because somewhere, someplace, some part of the country, every 10 seconds, every 10 minutes, someone is succumbing to breast cancer. You would have gone a long way in saving the lives of those who are close to you. A nationwide strategy by individuals, hospitals, NGOs, partnership with the government of India can improve the delivery of breast health care. I was so delighted when Dr. Arunima said that she was launching a foundation, a Sparsh Foundation in Jharkhand, to create awareness about women's cancers and pediatric cancers. More power to you, Dr. Arunima. If someone like me with an average or an above average intelligence can implement a program in Telangana and Andhra Pradesh, so many of you intelligent people, distinguished people, connected people with the government, with the people, you can make this a people's movement. And I wish you all the best in replicating this and I'm sure you can replicate this in Jharkhand. If your heart beats for early detection, you can certainly do so. Once again, very grateful to you and to the entire chapter for giving me this distinct honor. Namaskaram.
Very well spoken. My chairperson, Dipitender, can you take over and?
Yeah. As usual, it's a spellbound presentation by Raghu. And in spite of the fact that we have been working together for almost 1.5 decades, he never fails to inspire me as a breast surgeon and inspires me to carry on my work. And as a founder of ABSI, I know the background he created, and ABSI was formed in spite of the tremendous obstacles at that point of time. And he is the guy who is responsible for creating and giving breast a subspecialty which it deserves. Thank you, Raghu, for giving this subspecialty an entity. We are deeply indebted to you. And
you are no less, Dipten, you are no less, you are no less. Your contribution has been invaluable along with Som Shekhar. It has been invaluable. I am very, very grateful to you.
Thank you. Thank you. And once again, you have inspired so many of the trainees who are sitting in the virtual auditorium. And you must follow this gentleman way he created the whole story. Go speaks beyond breast, how to prosper, how to go up in the ladder and keep on motivating yourself. And thank you, chapter, for giving Raghu this wonderful opportunity to present in front of the upcoming surgeons and inspire them. Thank you very much, Raghu. Over to Dr. Sunil, please.
Raghu, Raghu has trained so many people. So I'm happy to announce that the person also who trained Raghu has just logged in. Can I request Rachel to say hello to Raghu? There was some concern yesterday. Can you make yourself visible and say hello to Raghu?
Hello, Rachel. Very nice to.
Hello, can you hear me?
Yes.
Thank you. Raghu, that was an absolutely fantastic talk. I am so glad that I heard it. It was absolutely inspirational. I think we need you to come back to Wales and inspire us over here if we can steal you away from India, because they are very lucky to have you. The work you've done over the last decade or 15 years or so since you've been in India is absolutely phenomenal. And I found that talk very inspiring. Thank you very much.
Thank you very much, Rachel. Can never forget, I never forget to express my gratitude. And it is because of the teachers, my parents and teachers, that I am what I am. And I can't forget, because I'm going to introduce you, of course, but you were my first trainer when I came to Wales in 2007 September, where you were a senior lecturer and a consultant surgeon appointed at the University Hospital of Wales.
Thank you. Thank you. Very inspiring talk. Thank you.
Okay, thank you very much. Arunima, back to you. Now we are done with it.
Just want to thank Dr. Raghu for introducing our organization Sparsh, which is almost in the process of completing the registration. And we would take help from you, sir, for launching that program here as well. Thank you very much. Yes, Sumegha, please take over.
Yes, ma'am. And this was the certificate of appreciation. Now I Satvir for the next oration.
Thank you, Dr. Anuma, ma'am. Thank you, Dr. Sumegha. And now we move on to our next presentation, which is Dr. A.K. Sahai oration. So Dr. A.K. Sahai oration, the speaker will be our president, Dr. Abhay Dalvi from Mumbai, and he will be talking upon looking back and looking ahead. We welcome our esteemed chairpersons, Dr. Jugal Kishore Chaudhary and Dr. Uday Srivastav. Our esteemed Dr. Jugal Kishore Chaudhary is a senior consultant surgeon at Deoghar. Sir has an MS, FIAS, FICS, FMAS, and FIGS. To talk about Dr. Jugal, we need to have much more time about it. But to be brief, sir is an executive committee member of 2019 to 21 ASI, and sir has been recently awarded with ASI Social Service Award in 2020 for rendering exceptional social services in the remotest part of the country. Sir has also been a COVID warrior for his continued medical and social service during his pandemic. We welcome you, sir, as a chairperson. Our next chairperson is our esteemed Dr. Uday Srivastav, sir. Sir is a consultant general surgeon at Apeksha Surgicare Hospital, Ramgarh. Sir has an MBBS MS, and sir is a chairman of Jharkhand chapter from 19 to 20 and a secretary to Jharkhand chapter from 16 to 2018. I request the chairpersons to invite our speaker, Dr. Abhay Dalvi.
I invite Dr. Abhay Dalvi, our incoming president, ASI, to give the oration, Dr. A.K. Sahay oration. Dr. Dalvi.
Could I share my...
Dr. Avnikant Sahay, oration. Dr. Avnikant Sahay, born on 26/1/1943 at Fatehpur, Gaya district. The only child of his parents did his early education at Gaya, then shifted to Hazaribagh and did his schooling from there. Passed from St. Columbus, Hazaribagh. He passed his MBBS from Rajendra Medical College, Ranchi in the year 1966. After completing housemanship, he worked in different specialties at UK, did his FRCS from Edinburgh, UK. He published articles in British Journal of Surgery and Lancet, etc. He joined Patliputra Medical College in 1976, retired from here as HOD surgery in January 2002. He was president of Dhanbad chapter of surgeons, president Dhanbad IMA in the year 2003, was president of Jharkhand Surgeons Association in year 2010-11, was an active Rotarian and a former president. Wife Pramila Sahay, blessed with two sons, elder son Dr. Vibhas Sahay, general and laparoscopic surgeon, married to Nitu Sahay. Grandson Aditya and Adivik, younger son Dr. Vikas Sahay, married to Svetlana Sahay, settled at St. Petersburg, Russia. Granddaughter Amelia. He left all his near and dear ones in tears after a massive brain hemorrhage on 26 December 2012. But a person like him carves his name and hearts. His legacy shall remain alive in mind of others and stories they share about him. Dr. Dalvi sir.
Thank you, Dr. Chaudhary. Can you see my screen, please?
Yes, sir.
Yes, sir. Yes, sir.
First of all, let me thank the state chapter of Jharkhand for bestowing upon me this Dr. Avnikant Sahay oration. I believe I was supposed to speak about him. So let me just shorten it off that he moved from Gaya as a child, went to Hazaribagh, went to Ranchi, and ultimately settled in Dhanbad. He was responsible, according to me, for actually developing the Department of General Surgery, because Pataliputra Medical College, where he was the HOD, was sanctioned in 1971 and he had joined in 1976. His two publications in British Journal of Surgery and Lancet are landmark because that paved the way of safe cholecystectomy and hernia surgery, as I read from the PubMed. He was obviously the president of the Jharkhand state chapter, as well as did a lot of philanthropic work in the Rotary Club. So in his honor, I deliver this oration looking back and looking forward. Let us see what is a surgeon. Surgeon is nothing but a poisoned goblet. Many a times surgery is successful, the patient dies. What are then the surgeon's problem? He may have the technical expertise, but the nature of the disease, the pathological changes that take place in a patient, and response of a patient to treatment determines the final outcome. If I have to look back into the history of surgery, this is a picture that comes to mind. The operating surgeon was usually garbed in a black Prince Albert coat, kept hanging in the closet for occasion, and showing numerous evidences of previous operations in the way of dried blood and wound secretion. Needless to say, most of these patients who were surgically intervened died of sepsis. Speed was the hallmark of surgery without anesthesia. This is Robert Liston, who was known for his speed and skills, but while operating on an amputation, he cut his assistant's fingers, as well as one in the audience also died. So he had 300% mortality in one operation. Two revolutions in surgery were advent of anesthesia by Bigelow and antisepsis by Lister. The picture on the right up is of Semmelweis, who brought in just washing hands to decrease the maternal mortality, which is so relevant in today's corona world. And then came Halsted, who introduced the concept of rubber gloves. Between mid-1800 and 1900, there were major advances in surgery because of the support forces of anesthesia and antisepsis. And surgery and the surgeon became dominant force. Lord Berkeley Moynihan always advocated large incisions for any abdominal operation. In fact, he said, big surgeons make big incisions. And that is how we were able to do real major surgeries that are done in a minimal access way today. William Halsted brought in the training residency system into this world, which has trained countless general surgeons today. The same thing is practiced even till date, where there is a 3-year residency system which is existent in India. In my time, we had optional rotations. So we could do general surgery, orthopedic surgery, plastic surgery. There was no entrance examination for subspecialization or super specialization, and there were less number of trainees who were under training for general surgery. My mentors assured that I developed technical skills which included clinical knowledge, judgment, decision-making, dexterity, and use of correct equipment. They also ensured that I developed non-technical skills, that is ethics, logic, psychology, communication, teamwork, and situation awareness. Not only did they do that, but they also ensured that I covered my syllabus, dissertation, etc., and also made me develop a relationship not only with my juniors and seniors, but even paramedical staff and patients. Through the years that I have graduated and now nearing superannuation, specializations came into picture. Plastic surgery, neurosurgery, surgical gastroenterology, urology, cardiovascular surgery, endocrine surgery all came into market. Surgical gastroenterology has now again developed into upper GI, colorectal, and HPV surgery. The third revolution came somewhere in 1980s when Kurt Sen introduced laparoscopy. Seeing him do a laparoscopic appendicectomy, in spite of being a gynecologist, settled with, in 1985, the first laparoscopic cholecystectomy. In India, in the world. In France, in 1987, Philippe Mouret was the first one who also performed the first laparoscopic cholecystectomy. On 31st of May 1990, my respected teacher, Professor Timton Udwadia, performed the first laparoscopic cholecystectomy at the Grant Medical College and Sir J.J. Group of Hospitals in Mumbai. That possibly changed the life all over for the surgeons in India. I was destined to become an engineer. And joined as a staff in 1986 at St. G.S. Medical College. Graduate sometime in April next year. But I have to go on record that I was blessed with proper mentors and even mentees. Over these years, when I graduated and there were no investigations like ultrasonography or even endoscopy. I have seen the development
Charing Cross and Westminster Medical School and undertook training posts in and around London. Her first training post as a registrar in Johannesburg was in fact the defining moment of her training. A cancer research campaign clinical research fellowship led to an MD degree, and then she was appointed as a consultant surgeon in Abergavenny in 2000. She then moved on in 2007 to the University Hospital of Wales as a clinical senior lecturer, her main interest being colorectal surgery and especially familial cancers, anal cancers, and intestinal failure have been her special interests. She has served on a number of committees on the All Wales Surgical Training Committee, Executive Board of the Welsh School of Surgery, the Welsh Board of the Royal College of Surgeons, and she has been an active member of the Royal Society of Medicine, which is an organization that is responsible for conducting a number of CME activities, and there are a number of subsections in that, and she's been a very active member of the surgery section of the Royal Society of Medicine, for which she has also served as the president. She was also the council member of the Royal Society of Medicine and has also served as a treasurer. She has served as a member of the Executive Committee of the British Association of Surgical Oncology, the Management Board of the National Institute of Clinical Excellence, National Collaborating Centre for Cancer, and an active member of the British Society of Gastroenterology and British Society of Gene and Stem Cell Therapy. So she has, a very extensive experience, but what I'd like to highlight is in the year 2017, she was conferred the Surgical Trainer of the Year by the Association of Surgeons in Training. This is the highest recognition that is given by this independent professional body and charity that promotes the highest level of surgical training in the United Kingdom. It is extremely difficult to get selected. It's a robust selection process which involves, looking into various aspects such as leadership, resourcefulness, training and development, professionalism, and communication. And she is the only lady, if I'm not mistaken, in the 20 years since ASIT was formed, that she has been conferred this very prestigious honor. And it is well and truly a great pleasure to welcome her virtually to India. She, of course, will be participating in our flagship annual conference as well. And she's here today to deliver Dr. Das' oration on enterocutaneous fistula. Welcome, Rachel.
Thank you. Thank you. Many teachers par excellence and a legendary personality, having a very soft and polite behavior towards his colleagues and students. He was one of the founders of the Association of Surgeons of India, Jasicon chapter, and was respected as a guardian of the chapter till the end. He actively participated in state, national, and international conferences regularly, and it is a great loss to the Jasicon chapter as he's departed for his heavenly abode at the age of 87 years. May he rest in peace. Thank you. I'm very honored to be invited to give this oration in his memory. And I'll just share the screen. I hope you can see it. Can you see the screen? No?
Yes, we can, Rachel.
Great.
Yes, we can see the screen.
Lovely. Great. I was reading about Dr. Das, and I was so impressed by his abilities as what we would consider as a true general surgeon. His clinical practice encompassed not just abdominal surgery, but the range of general surgery, including plastic surgery. And through that, he was able to teach and mentor and train a whole generation of surgeons, many of whom have gone on to very successful careers of their own. I think that is something that I, and indeed all of us, would like to emulate. And I'm very honored to be invited to give this talk in his memory. The topic for the talk is intracutaneous fistula, which is something of an interest of mine that I've developed over a number of years. And in fact, I think plays into what I've just said about Dr. Das, because intracutaneous fistula occurs in many general surgical situations. I have no conflicts of interest to declare, but I do apologize for the confusion over the timing yesterday. I'd like to take you on the journey of the lessons I have learned over the last 25, 30 years since I was a medical student at the Charing Cross and Westminster Medical School. And it was there that I learned the basics of science, the anatomy and physiology and pathology of the intestinal tract and digestion, secretions, physiology, so that I began to understand what a devastating physiological insult an intracutaneous fistula could be. As I progressed through surgical training, as Dr. Raghu has mentioned, I did my first registrar job in Johannesburg, and it was there that I learned the importance of surgical resuscitation and particularly emergency surgery in terms of how to avoid intracutaneous fistula and other complications. Towards the end of my training, I was a resident surgical officer at St. Mark's Hospital in London, which at the time hosted one of only 2 intestinal failure units in the UK. And it was there that I learned about the importance of getting a really good total parenteral nutrition service in line with the surgical service in order to care for these patients. And in recent years, I've practiced at the University Hospital of Wales, where this has become a major part of my practice. And I've developed my thoughts, learning some hard lessons along the way about how to manage these patients long term. Now, I'm sure that many members of the audience will have their own personal copy of this book on the right of the slide, The Famous Bailey and Love. I often say to the trainees, you can't be a proper surgeon unless you own a copy of this book. And so I went back to my rather battered copy of the book and I looked at what it said there about the etiology of intracutaneous fistula. And as you can see, there's quite a long list on the left of causes of intracutaneous fistula. And in the chapter, it emphasizes some of the common ones at the time, which are things like diverticular disease, Crohn's disease, colon cancer. It also mentions a number of infectious causes. But in my practice in Cardiff, I don't see any of the infectious ones, although I am sure that in India, you do see TB and some of the other ones fairly frequently. Unfortunately, what I do see in Cardiff are predominantly post-operative intracutaneous fistula. And this is borne out by my own practice. I've reviewed our patients who require long-term TPN, most of whom have intracutaneous fistula. And as you can see, 10 years ago, the single biggest cause of requiring TPN, as evidenced in the blue segment, was inflammatory bowel disease, mainly Crohn's. But when I looked at this year's patients who've been put onto long-term TPN, you can see that actually the biggest single cause is the orange segment, which is post-operative complications. And for the fistula patients, this is even more true. The Crohn's patients are actually a very small segment now of intracutaneous fistulae presenting in Cardiff. And the orange segment, the vast majority, are unfortunately post-operative fistulae, comprising over 80% of the fistulae we deal with. And this fits in with the literature where some of the more recent papers have shown quite high proportions of iatrogenic or post-operative fistulae. So this brings me to the second lesson that I've learned over the years, which is that we must try to avoid intracutaneous fistulae. Now, intracutaneous fistulae can occur after either elective or emergency surgery, but it's particularly more common after emergency laparotomy. And it was in Johannesburg that I learned the principles of emergency laparotomy. Really, you're trying to achieve one of three things. to stop hemorrhage, to relieve obstruction, or to drain sepsis, which means removing any necrotic bowel as well as any other ischemic tissue. And the emergency situation is not the time or the place for dealing with incidental abnormalities or correcting every little thing that you find wrong. It's important to just do the things that are necessary. Iatrogenic intestinal fistulae break down, I think, into 3 groups. There are an unavoidable group where, as the surgeon, you just think this could have happened to anyone. One has undertaken a major operation, such as an anterior resection or a cystectomy, which has to be done, or one is doing operation in a Crohn's patient that has had multiple operations before, or occasionally operating on a desmoid tumor. And complications can happen even to the best of surgeons, and a fistula results. These are unavoidable. We all worry about technical errors, but in my experience, these are quite a small proportion of the fistulae that we see. There are occasionally catastrophic problems from a complete failure to identify the anatomy correctly, but those are very few and far between. What happens more frequently is that at the end of a long and difficult operation, when everybody is getting tired, the small bowel gets caught in the wound closure, thus allowing a fistula to form. And I think it's really important when you are tired as a consultant, not to go off at the end of the operation, leaving the resident to close up the wound with no assistant, but actually to stay and let the resident do the closure with you assisting, so that you can pull on the suture and keep the small bowel and the abdominal wall separated. Unfortunately, though, a large proportion of the intracutaneous fistulae we see are due to errors of decision making. And these vary from some common themes, such as performing an anastomosis under adverse circumstances, or the inappropriate use of a mesh or a vacuum, through to more difficult to define problems where one wonders why the operation has been done in the first place, or where repeated procedures are being done. And looking at these, some are due to simple lack of experience, and others are very bizarre, where you just wonder what the surgeon was thinking at the time. So I have come to conclude there are some principles about what to do and what not to do in order to avoid fistulae and keep out of trouble. I think when performing an anastomosis, one should not do this if the patient has low nutritional bloods, particularly low protein, low albumin, and one should not be doing an anastomosis in a cold and acidotic patient at the end of a long operation. And it's Murphy's law that anything you join together the day before you go on holiday will probably leak as well. So I think that it is better to bail out and give the patient even a high stoma if necessary, because that's a temporary problem that you can come back and deal with later. Nutritional support has improved so much in the last decade that even quite high fistulae or high stomas are relatively easy to manage with TPN, and that can buy time for you to go back and do restorative surgery. Now, as I mentioned, I learned a lot of these principles when I was working in South Africa, and the guy in the red shirt in this photograph is the best surgeon I have ever had the privilege of working for. He was called Mario Suarez. He worked in Johannesburg. He was a very brilliant technical surgeon and a very strict trainer who would hit me with the instruments if I was doing things wrong. But he always said the first time is the easiest time to get things right, which is why one should avoid getting into a cycle of repeated operations. I think it is unlikely that a patient is going to need more than 3 operations. The first operation is done to deal with the presenting complaint, whether that's an elective operation for cancer or an emergency operation for hemorrhage or obstruction or sepsis. It may be necessary to do a second operation if you plan to relook an emergency patient because you've been unable to close the abdomen, or occasionally one has to do an unplanned relook laparotomy for leak or sepsis or whatever. And the third operation may then be necessary to wash out and close. But if you find yourself doing 4, 5, 6 operations over a short length of time, and we do see this with the patients that are referred to our unit, I think that one should stop. Stop operating and stop to think about the situation. Reassess what is going on. You may wish to take a second opinion at this point, and then take charge of the situation. And at this point, one normally has to regain the confidence of the patient and family, because obviously things are not going according to plan. The third lesson I've learned is to avoid mesh directly on bowel because of the risks of adhesion, fistula formation, and perforation. Now, many of us will have spent time with the representatives of various commercial companies who assure us that their particular mesh will not cause any problems with the bowel. But myself and other people who work in intestinal failure units have seen fistulae through all of the meshes on the left, including vacuums and some biological meshes. I personally have not seen a fistula as yet through the meshes on the right. And this leads on to the fourth lesson, which is whether one should do a laparostomy or not. And my thinking on this has evolved over the years. In general, the first time is the easiest time to get things done. So therefore, if the sepsis is cleared and if the abdomen can be closed technically, I would choose not to form a laparostomy on the grounds that your best chance of getting the abdomen closed without future complications is the first time. However, occasionally it is necessary to perform a laparostomy. This needs to be done if one is definitely planning to relook the patient because of the potential for unresolved sepsis or ongoing ischemia. Also, if one is unable to get the bowel back into the abdomen without raising the intra-abdominal pressure such that it would impair respiration, one may have to perform a laparostomy. And I'm sure the surgeons in this audience will each have their own favorite way of performing a laparostomy. There are many different commercial and homemade devices available. I think whatever device you choose to use, certain technical points should always be remembered. The bowel in these cases is extremely friable, which is one of the reasons why the patient is in trouble in the first place, and therefore it needs to be handled with extreme care. Whatever you decide to put on the bowel must not be adhesive. So whether it's a homemade bag taken from the bags which hold liters of saline, or a commercial dressing of some sort, or a soaked gauze roll, you must use something that is not adhesive. And in the case of the latter, it should be removed within 48 hours. If you decide the patient needs to have a chronic laparostomy and that you're not going to attempt to close the abdomen, then I think that a wound manager is very helpful for nursing care, and indeed patients can be taught to change wound managers themselves if necessary. My thoughts on a VAC have evolved over the years, and I now take the same position as the Salford intestinal failure unit, which is if the abdomen has no fistula present, a VAC should not be used. However, if a fistula is present, then there is nothing to be made worse, and a VAC may be the best option for hygienic nursing care. And I think these all play into the lesson that I have learned, which is about attention to detail. These patients are extremely high maintenance and require the input of a lot of vigilance in the perioperative period. Sepsis is what kills these patients and may occur anywhere. They have a number of indwelling lines and catheters, which may be a problem. They've often had long operations and have atelectasis predisposing to chest problems. And of course, the abdomen may be the source of ongoing sepsis. And during this time, they are very catabolic. They need full nutritional support along with the paramedical specialties as listed here. I really learned about the importance of nutritional support when working at St Mark's Hospital in London. The nutrition support team, which is present in many hospitals now, provide nursing care which looks after lines with huge attention to detail in order to prevent line sepsis, which can prove fatal. These patients also need to undergo regular and frequent blood monitoring, and one needs to be looking after patients with a high output intracutaneous fistula in a unit where the pharmacy can prescribe personalized prescriptions, because many off-the-shelf preparations that you buy commercially do not provide the right TPN requirements for these patients. And not every hospital is able to provide a pharmacy which can produce both lipid and non-lipid TPN for the protection of these patients' livers. And this brings me to my most important point, which is that all of this really extols the virtues of a multidisciplinary team. This is the team I'm very fortunate to work with in Cardiff, and as well as gastroenterologists and a surgeon, the bulk of the team is made up by nurses from stoma care and nutrition, pharmacists, dietitians, psychologists, biochemists, and a manager who makes sure that we are able to do this. The team approach takes us right back to medical school. And many of you remember the aide-memoire on the right of the slide, SNAP. Sepsis is the most important thing here, and the whole of the patient's journey should be aggressively directed to resuscitating the patient and to controlling sepsis. Nutrition, as I've mentioned, is essential. Later on down the line, the anatomy will need to be defined, and this can be done by cross-sectional or contrast-mediated radiology. It is important to have a radiologist who is interested in this sort of work, because these patients often need many different investigations. I would say, however, that in recent years, the quality of CT scanning is now so good that fistulograms are much less rarely performed than they were a decade ago. And as a surgeon, we always think that surgery is the most important thing, but actually the procedure that is going to put these patients right comes quite a long way down.
Hello. Am I audible? Hello, am I audible?
Hello.
Hello, am I audible? Oh,
Hello.
Hello, am I audible, sir?
Yes, yes.
Okay, sir. Welcome you all. I hope I'm not disturbing you for you must be feeling sleepy after lunch.
मेरा वीडियो ऑन कर
शेयर स्क्रीन वीडियो
हेलो सुशील
Good afternoon, sir. Just starting the
इसमें इंडिया टुडे बना गुड आफ्टरनून
Good afternoon, sir. Jha sir, good afternoon.
थैंक यू
afternoon, sir.
चालू हो गया should I start
No,
should I
sir.
start or wait just
Good afternoon, Jha sir.
oh good afternoon इसको चालू नहीं ना किया अभी good afternoon इसके बीच में thank you
I will request the delegates to switch off to mute themselves.
sound why is this
I welcome our chairpersons, Dr. Nishit Ekka and Dr. Arshad Jamal.
Thank you, Dr. Sushil, sir.
Thank you, Dr. Sushil,
for the invitation.
sir who introduce him please introduce
Kindly introduce Dr. Ekka.
Okay, sir. Thank you very much. Good afternoon, everyone. Now, I get the privilege to introduce Dr. N.K. Jha, sir. Now, he was my teacher during my undergraduate and my postgraduate times. So, it is really a privilege to introduce him. Professor N.K. Jha, sir, who is currently at Narni Medical College and Hospital in Rohtas, has been our ex-head of the Department of Surgery of RIMS. Under him, I was a senior resident, and when he was assistant professor and associate professor, I was a postgraduate. Dr. N.K. Jha, sir, was passed his MBBS as a 1995 batch student, and he did his MS in 1979. He joined in the services as civil assistant surgeon from 1978 to 1982 at Nimidi PHC, Jharkhand. He worked as a resident surgical officer from 1982 to 1986 at PMCH Patna, registrar of surgery from 1986 to 1990 in SKMCH Muzaffarpur. He joined as assistant professor of surgery at RIMS Ranchi in 1990 and was there till 1995 as assistant professor. He joined as associate professor in 1995 and he was associate professor till 2008 at RIMS Ranchi. He was promoted as professor of surgery from 2008, and he retired or superannuated in the year 2016 as professor and head of the Department of Surgery. Professor N.K. Jha, sir, joined NMCH Rohtas after his superannuation from RIMS in 2018, and he is still working there as professor and head. Thank you, sir.
May I start sharing the screen, sir? Kindly start sharing the screen, sir. Jha, sir.
yes so I should share now
Yes, sir.
thank you Dr. Nishit for my introduction. It is a great matter of pleasure that both Dr. Arshad and Dr. Nishit, presently the trainer of one of the premier institutions, and they will be delivering the same portfolio which I delivered there and on the topic which I am going to discuss. So it is a great incidental finding. I wish Both of you should continue as a successful trainer for coming trainees. With this topic, I am going to tell about the surgical training, which needs no more works than words. Truly speaking, training needs more work than words. Next one.
Jha sir, can you please maximize your, can you please click on the...
Yes, I'm just. Now?
Thank you, sir.
Yes, sir.
So this is the workplace where I'm working, and it's a great privilege also to have this online working and improving our the technical skill. What makes different the surgical skill from the other skill is that surgery is that branch of medical science that has to deal with therapy carried out by our hands. We touch the life. So our discipline is based on humanitarian ground. So training is very important so far surgical skill is concerned. But there are many limitations in this training for the trainee, like increasing complexity of the cases, operative room efficiency that matters. It at and every places regarding the efficiency of operative room, we know it. Third is mitigating surgical errors and shorter work week for residents. And lastly, very important line is that practice on patients is no longer acceptable now. So these are limitations for the trainees, how to train them by trainers. So we have to overcome it. What type of skills we have to develop is mainly two, that is economy of the movements, and second is the lightness of the touch. Now, what does it movement we are concerned? We talk about the fast surgery. It is nothing like fast and fast. It is the symphony of the hand movements that makes your surgery smooth and assessed by the non-technical observers. So your symphony, your coordination of the hand movements, first point, and second is lightness of touch, which we can understand by simple example of using hemostat in the form of catch, clamp, and crush. That gives the idea of the tissue respect. Mastery is the end point of this skill. So we can, to be expert, we have to do mastery, and that is competency based. Remember, that is competency based, and ingredients for competency is cognitive interaction, that is mental rehearsal, and feedback and long repetition. So that is one part. And second is the training in operation room may not be possible all the time. So we have to go for other alternative way for trainings. Skill attainments needs practice, no doubt. Any skill we needs practice, and deliberate practice is required. And the procedures must be trained, must be shown to the training by many ways, like a deconstruction and other ways. You have to tell the trainees. There are certain stages of the skill training. One is, and that is by 3-stage theory of Posner's, Fritz and Posner, we must be, and we teachers should know, we mentors should know. One is deconstruction of the task. Now, this deconstruction means breaking the steps to train point to point, basic to basic. That is deconstruction. Second point is performing with more economy of movements. Economy movements that gives you more and less and become more automatic. The moment you are commanding the first part, second part will automatically improve, and third it become automatic. We do surgery reflexly. We have not to do mental rehearsal and anything, but our hands go on working it. So that is the third stage of learning. Simulators and motor skills learning are the substitute to combat the limitations of the training, which I told in the previous slides. So these are the based on your first principle, and simulators of different fidelity, high fidelity and low fidelity. Simply, we should know that high fidelity have very costly one, but
it controls all your ergonomics, all your errors, all your movements, and that's tell you that how to improve. So deliberate practice under the supervision of high fidelity make the surgeon expert. Boot scams are the example for this motor skill learning in the Royal College of Ireland is going on. And the rationale of rule of 90 degree, we know it. The moment the needle touches the skin, it should go perpendicular, it should enter to tissue perpendicular and make a circle, because your needle is a part of the circumference. Though circumferential movement of needle is, if controlled by 90 degree, the skill will be better, meaning thereby suturing will be better, approximation will be better. So that is rule of 90. So these are the simulators. I am not sure how many institutions are providing this, but they are very good thing for learning outside the operation room. So different simulators I have just produced for you to have idea of this. So how the skills are learned outside the operation room, outside the operation room. So these are some. Now this is model of learning. This model, you know, and this model, there are so many models. If you remember, we used to told see one, do one, and teach one. That was the surgery active. Now here you find the knows how, shows how, and does. So finally, we have to be cognitive knowledge, problem-based multiple choice question, essay like all that. These are the knowledge concern. So once you command on this, then you can switch over this shows and this performance stage. So this is the one of the models. Now this is what is diastolic learning. Simply, our surgical skill has been parallel with the cardiac cycle, systole and diastole. It takes no time whether the trainee or trainer is passing a needle to the skin. It is equal. But the second pass, it makes a difference. To take second bite makes difference. And the factors responsible are the diastolic factors. And those are ergonomics of setup, posture, positioning, handling of the instrument. These are the diastolic factors. So these factors are already tacit, hidden in the expert, which they have earned in time and practice. So trainee have to practice for these things. So these diastolic factors is very important to make you more competent and successful performance. Deliberate practice, which I told you, it repeated practice matters. So we should do that. A role of competent surgeon, we know 30 to 50% reduction in avoidable complications. Decision making is crucial once you are experienced, and particularly in stress. Surgeons are always in stress, and your decision matters. Able to apply professionalism, skill, knowledge, attitude by expert surgeon. Continuing program, CME, you know, it is just a refueling of the knowledge. If you compare with the aeroplane, aeroplane also needs some refueling to continue flying. So similarly, if you want to be updated, you should go through the continuous training. Development of competence. How to develop? You know, some are inherent quality which grabs early. That is one. Second, factors are also important for the surgeons for task execution, and that is non-technical skills. I will tell later. Competency and proficiency is interdependent, and competency is always priority and performance based. If you are competent but your performance is not seen, then the skill remains pending. Groups of surgical ability. There are three types. Basically, three types. One is the inherently will catch it as early as possible. But second group is that second group able is to reach competency with repeated practice on simulators. And third group unable to reach basic competency despite repeated practice. So that is the three groups. There should be traits of the surgeon. The trainee and trainer both. Trainee should have motivation. Trainers should motivate also, dedication, discipline, speed and power, and tacit knowledge. And lastly, he must have the knowledge of basic science. That the cognitive part is equally important. These are the workplace-based assessment where your skill will be assessed. For us, the clinical encounters we practice and procedure-based assessments or devices are there to assess your assessment. Postgraduate surgical training in India, well known. It is nothing new for us. It is up to the postgraduate where they are placed, high volume center, low volume center, setup issue, like all these things that matters for training. But the 3 years is the golden period of competency if one gets chance. Postgraduate surgical training again. One thing which I asked morning schedule, that there is no curriculum for laparoscopic surgery, which is the need of our, because every passing surgeon is want to be good laparoscopy surgery. So there should be one curriculum for laparoscopy surgery. Training on simulators in some institution, not all institution. Now these non-technical skill. When we talk about surgical skill, we talk about skin to knife. Our aim how to cut the skin, how to close the skin. But there are important non-technical like briefing and debriefing. Mini medical education to the attendant, to the patient is important. And second, debriefing, what is the end result? If you take in the aeroplane flight, so our landing, our flying, our takeoff matters. Similarly here also, human factors, teamwork, failures, communication failures, disruption, operation flow, all matters in your performance. If the team is not good, whatsoever you are competent, it will be failure. So personal qualities and attributes also matter. These are the personal qualities, professionalism, technical competence, motivation, like all that. So golden rule is fit the operation to the patient, never patient to the operation. This is the golden rule. Be careful, thorough and meticulous in your operating, but by all means, do not be putter. Do not touch any tissue unnecessary, or at best it is traumatic. So we should have tissue respect. And lastly, the teamwork is the surgeon's great asset. So by all means, avoid becoming a prima donna. Never be prima, the solo player. That looks, that appears better, but in the long run, it is not fruitful. Always be your own most severe critics. You rectify, you improve, because you have to train. You will get the chance of many training under you. So be critic of yourself first. And lastly, let me emphasize the importance to the surgeon on his better half. That it plays important role. So take home message, what I can give you, that simulation is important component of the training program. For example, boot camp, if the operation room efficiency is not sufficient, you are not getting sufficient number of people, don't waste time, because 10,000 hours training in the operation room, outside the operation room is the standard timing for training. So you devote your time either using the simulator. Surgical simulators enable the safe acquisition of operative and non-technical skills. Models and practice should mirror like operation room working. So they should feel that I'm working in the operation room. So such simulators are also coming in way, but they are very costly. Technical and non-technical skills both are important for expertise. INET factors and delivery factors, they are very important for consideration. So I can say the surgical experts are in fact made note. So it's very clear, to cover up is unforgivable, and to fail to learn is inexcusable. Thank you.
Thank you very much, sir, for excellent deliberation. And you have emphasized again that tissue respect is the prime concern, and we should strive to strive to improve our skills, which can be done not on the patients but on the simulators, which is a better way to improve ourselves than at the cost of the patient. And we should be our biggest critic. That is absolutely well said. So thank you for enlightening us and guiding us in this, sir. Any more thoughts? Hello, am I audible? Hello?
Yes, yes, you are audible.
Yeah, so it was a great deliberation by sir. He has emphasized again that we should strive to improve our skills, have tissue respect, and improve our skills by the use of simulators rather than trying to improve on the cost of the patient. That's a good thought, and all the surgeons should practice that. We should be very careful in our development of our skills. We should not be callous towards the patient. Big thought from the sir. Well said, sir.
Dr. Eka, you want to say something?
Any words from chairperson?
Dr. Nishit Eka has muted himself.
1 minute. I think you can hear me now?
Yes.
Yes. Thank you, sir.
Okay.
It was a great
Welcome.
deliberation. It was a great deliberation, sir. You have always been our teacher and you have always been an inspiration. Sir, I had a opportunity to work on these simulators some time back in Mumbai, in CMAST, where
Yes.
I got some training in hands-on training in this upper and lower GI endoscopy interventions and all those things. But one thing what I observed was that, sir, it is too easy to work on simulators. And when you do the same thing in a patient, it becomes much more difficult. So simulators make it look very, very easy, especially the colonoscopy part, which I thought was so easy. It took me, say, just a few minutes to reach the cecum. But whenever I do colonoscopy now in our OT, it takes me not less than an hour to reach the cecum.
Definitely.
That is what sir has emphasized, I think so. That is what is the difference between the high fidelity simulators and the low fidelity stimulators. The low fidelity stimulators don't actually mimic the real life scenarios as good as high fidelity. And the high fidelity will actually challenge you into getting the skills right. Because you are right that low fidelity simulators can actually give you a false perception that the thing is easy, and you face a difficult and different scenario in the OT altogether. That is why there is a need of a high fidelity.
What I want to add, they are the alternative for training. If the high volume centers you are attached and you are getting the chance, then that not required. But if you are not getting those chance, then low fidelity, I think, most important than the high fidelity. High fidelity is very, very costly and not feasible to everywhere to get this one. And second thing, the traditional training, basic training, basic application knowledge, that still matters. That is technological training. Okay.
Thank you so much, sir. Thank you so much, sir.
Okay.
Sir, kindly accept this e-certificate on behalf of the committee.
Thank you.
And I also thank our chairperson, sir, Arshad Jamal. Kindly accept this e-certificate because only we can provide
Dr.
this
Sushil. Thank you very much.
Thank you so much for taking your time out. Thank you so
Where
much.
can we get this certificate printed from, Dr. Sushil? It is showing here, but
I will
to get how?
WhatsApp you. I will WhatsApp.
Sorry?
I will WhatsApp you.
Your voice is not coming properly. I was asking that it is visible here. Where can we see this images later on?
Yeah, I will WhatsApp you this. I will mail you this. and it can be.
Okay. Will it be available on the website? Will it be available on the website?
I think so. But
I also think so.
I will WhatsApp you.
Yeah. Okay.
Thank you so much, sir.
Thank you, sir.
Our next speaker is Dr. Ansul. I welcome the chairpersons for this speech, Dr. Aman Srivastava and Dr. P.P. Chawla. Dr. Aman Srivastava, are you here, sir? Dr. Chawla?
Am I audible?
Yes, you are audible.
Yeah.
Yes.
So thank you, Dr. Sushil. And good afternoon, everyone. Should I introduce Ansul?
No, let me introduce the chairpersons first.
Okay.
Dr. Aman Srivastava, MS, FIS, and MS, is a consultant general and laparoscopic surgeon and works in PM Memorial Hospital, Chas, Bokaro. He has been the vice chairman of ASI in Jharkhand and was the secretary of a very successful Jasicon 2015. Dr. P.P. Chawla sir is MS FRCS. He is a senior surgeon from Jamshedpur. He worked in England and then in Jamshedpur. He retired as a director of Tinpet Hospital, Jamshedpur. Chairpersons now can introduce Dr. Ansul Kumar.
Thank you, Dr. Sushil. It's my pleasure to introduce Dr. Ansul Kumar. After doing his MCH, Dr. Ansul is currently heading the Department of CTVS in RIMS Ranchi. He, with support from RIMS administration and his colleagues, has established this super specialty department at RIMS, which is the only running government cardiac surgery center in the state of Jharkhand. He had the honor of performing the first open heart surgery in the government setup in this state. He has more than 25 international and national publications and has presented papers in several conferences and seminars. He also actively involved in organizing different health and wellness camps. So today he will be talking on pseudoaneurysm of peripheral arteries, its presentation and management. It's my pleasure to invite Dr. Ansul for his presentation. Dr. Ansul, please.
Good afternoon, everyone. Thank you, Aman sir, for my introduction. And one thing I want to stress that I did my MS from RIMS itself. And whatever I am today is because of my Department of General Surgery RIMS. And of course, by blessings and well wishes of all my seniors and all my senior, junior and contemporary colleagues presently in this, participating in this Jasicon. So, sir, directly I will come to my topic. One, I will just correct myself here that actually my topic is acute ischemia, evaluation and decision making. There was some, I think, issues because of which the topic was changed later on, but I requested Arigma madam to give my original topic back and she readily agreed. I'm very thankful to her also. So, start the topic.
Yeah, kindly share your screen.
Yeah, sure. I'm just doing that. Is visible? The PPT is visible?
Not yet.
No, it's not
coming.
visible.
Yes, it's coming. It has come.
Change kar diya.
It is there. Kindly make it full screen.
This is visible?
Yeah, it's visible.
Yeah, I have made it full screen. Yeah, thank you. So, my today's topic is acute limb ischemia, and under this we will base our discussion on evaluation and decision making. So, we all know that one of the challenges encountered by both vascular specialists as well as general surgeons, and in case of diagnostic error, it has a very high price to patient with regards to both amputation as well as death rate. Actually presents as an end of life condition with multiple comorbidities associated with it. And sorry to say that there is no differential treatment as of yet of this particular acute limb ischemia. And selection of most appropriate intervention is critical to the patient outcome. Now, in the etiology and pathology, we all know that trauma, iatrogenic causes, as well as arterial embolism and thrombosis all contribute to the situation of acute limb ischemia. So coming to embolism, we all know that both cardiac as well as non-cardiac embolism contribute to acute limb ischemia. In cardiac embolism, we have got atrial and ventricular causes. Atrial causes means if the patient is an atrial flutter, that is, if he has or she has some pre-existing cardiac disease, particularly valvular disease, that can cause cardiac embolism. Ventricular embolism can arise from ventricular aneurysm if the patient suffered from, if the patient had some, ischemia, like for example, myocardial ischemia, and that led to ventricular aneurysm, that can also lead to cardiac embolism. Paradoxical embolism, we all know that it causes right to left shunt. Right to left shunt causes paradoxical embolism. So if any young patient with DVT presents with sudden onset limb ischemia, then the first thing that should come to mind is paradoxical embolism. So that is the most common presentation. Besides that, we have cardiac tumor, particularly left atrial myxoma, which can cause embolism. And of course, endocarditis. For example, in those patients who are chronic IV drug abusers of illicit drugs, those patients can present with cardiac embolism. In non-cardiac embolism, we have atherosclerosis and aortic mural thrombus, which can cause embolism, leading to acute limb ischemia. Now, historically, the most common cause, embolic occlusion, was secondary to valvular heart disease. But nowadays, cardiac emboli, because of AF, atrial fibrillation, as a result of ischemic heart disease, is the most common cause. But I will stress here that in India, still, the most common cause is valvular heart disease. Now, this data, this particular statement that cardiac emboli from cardiac atrial fibrillation from ischemic heart disease is particularly prevalent in Western countries. Dr. Chawla sir will stress, will know this fact that in England and other Western countries, this is the most common cause. Now coming to atherosclerotic obstruction, now coming to thrombosis, in fact, the etiology of which transcends these following things: atherosclerotic obstruction, hypercoagulable states. We all know the rule of Virchow. Vasospasm, aortic or arterial dissection, vasospasm, bypass, occlusal graft. These are all the major causes of thrombosis which can lead to limb ischemia. Now, what is the clinical presentation? So it progresses in steps, as we can all see in this slide. First, the loss of sensation, progressing thereafter to muscle weakness, that is weakness of motor nerves. Thirdly, involving skin. Now in skin, it will be initially dusky blue, and later on, the skin will have no blush on digital pressure. And last, involving the muscles. So any patient, if we are suspecting acute limb ischemia, and if he or she presents with muscle tenderness or muscle weakness, particularly tenderness, we can say that the acute limb ischemia has progressed to a very high stage and maybe irreversible stage. This is the figurative explanation how the acute limb ischemia progresses with respect to time. So as we can see in this slide, within 6 hours, it is particularly reversible. So we will have a painful marble white foot with neurosensory deficit, as I stressed in my previous slide. Within 6 to 12 hours, the limb will have mottled appearance due to capillary pooling, and there will be blanching on digital pressure. It is partly reversible. And if the duration of ischemia exceeds 12 hours, then it will lead to fixed staining with presentation of mottled areas, pulsing, and no longer blanching on pressure. And as I said earlier in my previous slide, that the muscle will be tender, and it is irreversible. So, first first is history and second is physical findings. So history should attempt to define cause, whether it is valvular heart disease or atherosclerotic condition. What was the patient's condition before he came to our clinic or to hospital with his condition? And secondly, as I said, that severe ischemia and irreversible muscle necrosis occurring within 6 to 8 hours. So in history, we will have to ask the was he or she suffering from some comorbidities previously, for example, hypertension, diabetes, any chronic illness, and the patient will present with if he or she is presenting with incapacitating pain or loss of sensation and power with acute white leg. So these are the things which we should keep in mind. But also at the same time, certain confusing diagnostic clinical pictures can be there, because sometimes musculoskeletal pain, sciatica pain can present with the same presentation as acute limb ischemia. So what are the physical findings? We all know that this rule of P, that is pain, pallor, paresis, pulse deficit, paresthesia, and poikilothermia. These are the basic, standstones of diagnosing acute limb ischemia. And secondly, a full vascular examination up to the level of, to know the level of occlusion is most important. So what things can help us in that? So most important is handheld Doppler. It is nowadays it is very cheap. It is available, and it can be procured at even community and primary health centers to have a initial diagnostic workup of the patient, physical diagnostic workup of the patient. So different signals can be there, soft monophysic signals. If there is no signal, then it is poor prognosis. Now, what is the classification? So as far as this classification is concerned, we have applied scenario. So there are 4 categories: viable, 3-8, 2A and 2B rated, both are 3-8, and class 3 is irreversible. As we can see, so viable is, it is not immediately 3-8, capillary return is good, muscle paralysis is none, there is no history loss, and arterial Doppler, it will be audible, and both arterial and venous Doppler will be audible. Class 2A is 3-8. In this, the limb is salvageable if it is promptly treated. The word here to be just out is promptly. And capillary return is intact, or it can be slow. There is no muscle paralysis. Sensory loss is partial. And arterial will be, Doppler will be inaudible, but venous Doppler will be audible. P is again treated, but it's salvageable if immediately treated. Now, this is the difference between 2A and 2B. That 2A is promptly and 2B is immediately. We cannot wait for 2B. So capillary return is slow or absent. There is partial muscle paralysis. Sensory loss is partial or complete. Arterial is again inaudible, but venous is audible. Now the third one is irreversible, in which there is no, it is irreversible as the classification is there. Primary amputation is the only treatment of choice. There is absent staining of capillary return. Muscle paralysis is complete. There is tense compartment, tender. Sensory loss is complete. There is both arterial as well as venous Doppler signals, both are absent. So this is very much important classification, which can guide us so as to how to treat a patient. So this is actually revised 2007 Transatlantic Inter-Society Consensus Guideline. So this is very good chart to be followed up in field clinical practice, even in hospitals, to triage the patients and plan their treatment. So how to locate the level of arterial occlusion? So clinically, aortic occlusion, there are different classification: aortic, iliac, femoral popliteal, popliteal, and infrapopliteal. So there are, as we all know that how to diagnose the level. For example, in aortic occlusion, there will be paralysis of legs. Patient will be definitely unwell. There is mottling of the skin extending above inguinal ligament. There is no palpable extremity pulses. In iliac, they are similar to aortic, but unilateral. That is important. Femoral pulse on the ipsilateral side will be absent. There will be mottling till inguinal level. In femoral popliteal, it is the most common presentation, in which the severity depends on involvement of profunda femoris. If profunda femoris is involved, then the situation is more grim. Now coming to popliteal and infrapopliteal occlusion, calf muscles are ischemic with palpable femoral pulse. And secondly, if it involves very distal emboli, then it is particularly difficult to treat. Investigation, how to proceed. So as I earlier said, that handheld Doppler is very good for screening. Otherwise, if there is imaging facility available, then we can, of course, the investigation of choice is CT angiography for acute cases. Ultrasonography, as already stressed. Transfemoral angiography is important when we are planning for endovascular treatment, and it requires a good setup, if with cath lab facility and all. MRA is not an investigation of choice because it is time taking. Many institutions, if talking about Jharkhand, we don't have many centers having MRA. And the last one is echocardiography, which is readily available at every centers, but echocardiography has only post-op role in evaluation of patients as to why the patient had this ALI and was the cause cardiac or otherwise. Initial management, you can go to anticoagulation. So it encompasses intravenous calcium heparin given immediately, followed by systemic heparinization, principally to restrict propagation of thrombus, although there is also evidence that it improves prognosis. In many units, low molecular weight heparin have replaced calcium heparin because of the more reliable effect on anticoagulation. I should stress here that in case of traditional heparin, we can reverse it with protamine. So that is one advantage heparin, not with low molecular. But still, yes, low molecular heparin has low bleeding rates. And there are other ancillary support measures, like for example, intravenous infusion is required for rehydration of the patient, and it is the best means of providing analgesia. If we have facility of patient control analgesia, that is the best option. But it should have a good anesthetic backup and maybe applicable in institute only or hospitals, big hospitals. And if thrombolysis is an option, then intramuscular analgesia should be avoided because of the obvious risk of bleeding. Venous blood should be taken for full investigation, biochemical and otherwise. ECG and chest X-ray may be of value in diagnosing and managing cardiac arrhythmias and heart failures. So this is the treatment chart, flow chart for acute limb ischemia. At first, we should, if once we diagnose ALI, then immediately we should start intravenous heparin injection. So different classification as I described earlier, that we have to classify the patient as to which stage he is or she is in, and accordingly we can direct our treatment. So all in all, endovascular treatment, surgical treatment, and hybrid therapy involving both surgical, medical, as well as endovascular can be employed, or it can be employed individualized also, depending upon the resources available. Intraoperative angiography, as I said earlier, that it may not be possible at all centers. So we have to individualize our patients as per their situation, as per our resources available to us. All in all the type of modalities can be employed. So these are some images which we images of the study which that this patient was actually presented to us. In fact, after 36 hours in emergency, he was admitted in Dr. Saravi's unit, and the call was given to us, cardiac CT-based department, and we did it in this 2 or 3 months back. So he presented with some wild animal hit the man in his infrainguinal part, and femoral artery was transected. It had a huge the segment. As you can see in this second slide, two ends of the femoral artery are visible, proximal and distal. In the intervening segment was injured because of injury, and we transected that particular intervening segment, and end-to-end anastomosis was done. And as you can see on the right side of the slide, we can all see long segment thrombus, which is present. So that thrombus we extracted from the femoral artery. Actually, the patient presented with not exact limb ischemia. He presented with limb ischemia in stage 2A. So we got time to investigate the patient. We did angiography, we did ultrasonography, and then accordingly we planned the patient. Meanwhile, we kept the patient on heparin infusion. So this is that the classification of patient as per the ALI that chart is very much important to plan our treatment. So we knew beforehand that yes, the limb is salvageable, and we plan our investigation and accordingly treat the patient. So this patient was treated accordingly. The below is the photograph of the limb, and the patient is fine. He's walking with no sensory deficit whatsoever. Now this is the second case, again presented with ALI, acute limb ischemia. That was actually, I even shared it in our group, in Jasicon group, that the young patient presented to us in cardiac OPD, based OPD with no pain of upper limb. There was no vascular compromise, but he only said that there is sir कुछ numbness है, मतलब sir कुछ हाथ जो है वो ढीला पड़ गया है. So we took the detailed history. We didn't find any comorbidities, but he said that he 1-2 महीने पहले ही चढ़ा था किसी बबूल के पेड़ पे और तब से उसको ये प्रॉब्लम है. So we immediately the limb was okay. So obviously the patient was in stage 1. We thoroughly investigated the patient, and it was reported that there is a foreign body which is compressing the brachial artery, and there is surrounding pseudoaneurysm which is leading to the sensory neural deficit distally. So we operated on the patient. We took the proximal control of brachial artery and then opened this. Luckily, the thorn was had migrated, and it was there in the radial artery, not in the brachial artery. So we took control of the brachial artery, and this thorn was extracted along with the aneurysmal cavity. So we were lucky enough that both patients entered in class 1 and class 2A. We have even operated class 2B patients with Fogarty in one setup. Some of patients were referred to the cath lab also at RIMS, in which they did intravenous angiography and they arteriography. I'm sorry, intravenous arteriography. They did arteriography, thrombolized the patient. The patient then was salvaged. And of course, we get many patients of class 3 in which the limb is unsalvageable, and sadly, those have to be referred to ortho or general surgery for amputation. So this was embolectomy which we did for upper ischemia. I'm sorry that I couldn't share the slide of the Fogarty being because my assistant lost the photograph somehow. So this is actually proximal brachial artery, in which, as we can see, just the thing which shiny thing which is seen is a proximal brachial artery in the mid forearm. So we took control of this proximal brachial artery and did incise the did arteriotomy and extract the embolus from. It was struck at the bifurcation of brachial artery. We did arteriotomy more proximally, so as to have a better control for bleeding and all that. So prognosis depends upon the medical state of the patient, and good prognostic index, and as well as pre-treatment POSUM. We all know about POSUM, physiological and operative severity score for the enumeration of motility and morbidity. So these things can be employed, but yes, I know that in clinical setup it's sometimes difficult. But still, thank you very much for kind patience. Thank you so much.
Thank you. Thank you. Thank you so much.
Thank you, sir. Thank you so much.
Thank you, sir. Chairpersons, you may ask questions, please.
Yeah, Chawla, sir. Dr. Chawla, please unmute yourself. I think there is no question from you. It open for audience also?
The audience may ask questions also.
Yeah. I think there is no question. Thank you, Dr. Ansul. I think we can finish this session. Yeah, thank you so much.
I thank our chairperson, sir. Let me share the screen. I'm facing some difficulty here.
Hello.
Yeah, Chawla sir is now. Yeah.
Yeah, I must congratulate you for the excellent presentation. I, being a general surgeon, I would like to ask you, what are the heterogenic presentation of ischemia, number one? Number two is, when do you really decide to amputate? How long do you take to take a decision for amputation? Because it's a very mutilating operation and bad for the patient. These two questions I would like to ask you.
Sir, iatrogenic presentation of ischemia, I should say that inadvertent arterial injection is the most common cause in our practice, which leads to acute limb ischemia in the patients presented to the hospital setup. So this is the most common, which I have encountered till whatever short experience I have. And second, as far as amputation is concerned, as I said in one of my slides, and as all we all surgeons are aware of this thing, that and yes, secondly, sir, I forgot to tell that iatrogenic limb ischemia can also be caused because of angiographic closure devices. Sometimes when cardiologists or cath lab people do, cardiac interventions for angiography and all, that can also lead to iatrogenic acute limb ischemia. So these two things we have encountered in our institutional setup, sir.
I see.
As amputation is concerned, sir, I will say that the patients presenting in class 3 stage, in which many of the patients present in those stages, sir, in which we find that limb is completely white, there is no, blanching of the limbs. There is on ultrasonography or even for CT angiography, there is no collateral development there. There is no distal flow, distal runoff on the vessels. These all objectively we say that these things lead to amputation of the limb or non-salvageability of the limb. Besides that, patients presenting in our emergency with traumatic injury of the lower limb, those patients also present with scenario in which amputation is the only choice. And thirdly, those patients who are admitted, who were in class 2A and class 2B, but because of some non-pharmacological or not proper pharmacological or interventions, those patients also present are referred to us for final amputation. So I must say that it is very important for all of us to timely diagnose and timely evaluate the patients with acute limb ischemia, because as I said in my first slide, that it has very bad out, as you said, that it is a very surgery. So our main aim is to prevent that, because it has both psychological and a social effect on the patient. So it is very important that once the patient presents with acute limb ischemia, the patient should be thoroughly investigated by both surgeons or the supportive or the nursing staff, and appropriately referred so as to prevent amputation. And I must say that the time is important, sir. Any patient, acute limb ischemia, within 6 hours, within 8 hours, he or she should be referred. If there is no facility available, he should be referred to some center in which there is some vascular backup available. I will not say that CT-based backup is necessary for that. Even all of us are general surgeons. Any surgeon can operate the patient, provided he or she has, analysis and treatment protocol clear in his mind.
Thank you.
Thank you very much. It was really an excellent presentation. I must congratulate you for the excellent.
Thank you, sir. Thank you so much, sir.
I thank our guest speaker, Dr. Ansukla. Kindly accept this e-certificate on behalf of the organizing committee.
Thank you, sir. Thank you.
And this e-certificate, kindly accept, our chairpersons, kindly accept this e-certificate, Dr. Aman Srivastava and respected Dr. P.P. Chawla, sir.
Thank you so much.
Certificate.
Thank you. Thank you very much.
Thank you so much, sir. We are on to the next guest speaker now. Our next guest speaker is Dr. Rakesh Kumar, and our chairperson, sir, Dr. Pankaj Bodra, sir, and Professor Vinay Pratap, sir. I welcome Dr. Pankaj Bodra, sir. Kindly take the mic.
Yes. Good afternoon, everybody.
Let me
Dr. Sutil, Dr. N.K. Chaudhary sir, P.P. Chawla sir, and my co-chairman, Dr. Vinay Pratap. And speaker is Dr. Rakesh Chaudhary.
सर आपका दो सिस्टम को ऑफ कर दें सर आवाज
Yes, yes.
सर थोड़ी
Hello, Dr. Bodra. Hello, Professor Bodra.
Yes, sir. Yes, sir.
Professor of surgery in RIMS.
Yes, sir. Good afternoon.
Am I audible also?
Yes, sir.
Am
You
I
are
audible?
Yeah. Yes, sir. Dr. Pankaj Bodra, Professor of Surgery in Department of Surgery, RIMS, is an examiner of various universities and DNB specialty examiner for the past 10 years. He has got several publications in the national and international journals. Professor Vinay Pratap sir is a professor of surgery in the RIMS, Ranchi. He's an examiner of MBBS and MS in various universities. He's a pioneer in starting laparoscopic surgery in RIMS. He has got several publications in national and international journals. Bodra sir, kindly introduce our guest speaker, Dr. Rakesh Kumar sir.
Dr. Rakesh Kumar is assistant professor in department surgery here. He has qualifications like diploma in laryngology, MS in surgery, MCH CTBS from AIMS Delhi, and started his career as assistant professor and started doing his surgeries in Department of CTBS RIMS, Ranchi. Till now, we have done. He has done more than 300 cases in the last 3 years. And is doing all kinds of cardiac surgery, thoracic surgery, and vascular surgery under one platform. He has published more than 20 papers and presented oral, video, and posters in national and international events. Chaired many workshops and in national conferences, and is planning his MCH cardiothoracic surgery in Jharkhand at our institute.
Sir, you have muted yourself.
Is it audible now?
Yes, audible, sir.
Again, I have to say again, this all Rakesh.
It's audible, sir.
It's audible now. No? Okay. And his CV, you heard his CV or not?
Yes, sir. We have heard it. Yes, sir.
Okay, thank you.
Rakesh, and we are proud of that.
Okay, thank you very much, sir. It's
You may start sharing your screen, Dr. Rakesh. Kindly start sharing your screen, Dr. Rakesh.
okay, sir. Just yes. Is it visible, sir?
Voice is slightly less.
Okay, sir. Now, how is it?
ठीक है अभी.
Okay, sir. Good afternoon, my seniors, my teachers, and all respected colleagues. It's my honor that
You have unmuted yourself.
Am I audible, sir?
No. Yes, yes.
Okay, sir. So, without wasting my time, I should start the presentation. Today, I'm going to deliver a lecture which will describe the spectrum of vascular cases in Jharkhand, how to deal with it, and what's the outcome of treatment. We have dealt with 200 different types of cases which we have came across in last 3 years at the Tertiary Care Center and an Apex Institute of Jharkhand RIMS. Emergency as well as elective, both cases included in this study, which were operated or managed conservatively in this period. This is a retrospective type of study, and limitations are single institution study with a small study group. There is no conflict of interest. 6 months to 82 years old patients were included in this study. Out of 200, 145 were male and 55 were female. Most common varieties of vascular illnesses are congenital category, patent ductus arteriosus, coarctation of aorta, arteriovenous malformation, and hemangioma. And in acquired is further divided into two types: traumatic and non-traumatic. In traumatic vascular injury was mainly in the peripheral arteries and veins, and broken intravenous line during the dialysis or peripheral artery pseudoaneurysm. In non-traumatic cases where arteriovenous malformation in different parts of the body, peripheral artery aneurysm, and deep vein thrombosis, acute limb ischemia, chronic limb ischemia, and varicose vein. Mode of intervention were surgical intervention as well as sclerotherapy and radiofrequency ablation. All traumatic cases were dealt with surgical intervention with excellent outcome. The limiting factor were the time lapsed after surgery and associated bony, soft tissue, and nerve injury with segment loss. In arteriovenous malformation, varicose vein, and others, sclerotherapy as well as surgery have excellent outcome. Patent ductus arteriosus and peripheral artery pseudoaneurysm repaired surgically with excellent outcome, and deep vein thrombosis and chronic limb ischemia managed medically, and they have good outcome in long follow-up. This is first case how we do ligate the patent ductus arteriosus. This in this picture, this is the descending thoracic aorta, and what we have looked is it is patent ductus arteriosus. We have reflected the mediastinal pleura both sides, and we identified the intercostal arteries, and some of the intercostal arteries are clipped here. By this video, you can see the descending thoracic artery, descending thoracic aorta, this one, and PDA. In this picture, you was able to visualize that we have doubly ligated the PDA, and there is no flow across. This is the child when she was going home. This was just 7-month-old child. This is a picture of arteriovenous malformation in a child of 3 years. The swelling was present at birth, but gradually increasing in due course of time. And when he presented to us, it was around 4 centimeter into 4 centimeter into 3 centimeter of size. And it was almost completely compressible. We excised it completely, and what we found that the feeding artery was radial artery. This was the child who was having congenital hemangioma on the dorsal aspect of his right hand. We excised this hemangioma completely, and later on there is almost minimal scar on his hand. This is a child who came with almost 3-4 transections at the level of right wrist. What you can see here, almost all metacarpal bones were exposed, all tendons were lost, radial artery was cut, and median nerve was cut. Meticulously, I repaired all the things in a sequential manner, and at last, he was able to move all the fingers. This is a 78 years old male patient who came from Dumka, Jharkhand, who was having gradual progressive swelling on the dorsum of right lower limb. He have given the history of trauma 3 months back, and the swelling was gradually increasing, and it became this much of size. This is almost a cricket ball size swelling. When we did the CT angiography of this patient, we found that the anterior tibial artery was traumatized, and that caused a pseudoaneurysm of in the right lower limb. When we opened that pseudoaneurysm, we found that this much of clot, almost half liter to 1 liter clot were there. We evacuated all the clots, and finally what we found, this is anterior tibial artery. There was rent in the anterior tibial artery, which led to formation of this pseudoaneurysm. This is a patient who came with almost 60% transection of the right hand at the level of elbow, with complete transection of brachial artery, radial nerve, and all the muscles and tendons. I repaired the brachial artery meticulously with 6-oproline and repaired the cutaneous nerve and radial nerve with 7-oproline and all the muscles meticulously. And finally, after a few months, he came in the follow-up with minimal scar mark. And in this video, you can see the movement of his all the fingers, as well as flexion and extension at the elbow joint.
Lovely.
Though at one moment, what our physiotherapists have told that he's having nerve injury, so his limb cannot improve. But I told him to continue the physiotherapy at home, and finally he came after 6 months with this. This is the patient who came with a gradual swelling for last 1 year over the chin. What we found that this was an arteriovenous malformation, and the mandibular artery was the feeding artery in this arteriovenous malformation. This was the patient who came with a swelling in the calf muscle, which was almost 4 to 5 years. He was giving history of swelling, gradual progressive swelling for last 4 to 5 years. When we did the CT angiography, we found that there was a huge network of the venous channels, arteriovenous channels, and the feeding artery were posterior tibial artery. So we almost ligated and debulked that affected limb. This was the patient who came with swelling in his tongue as well as his cheek for 2 years. And it was gradually progressing, gradually increasing. After excision of both the AVM, he was almost all right. There was no residual sequelae of the AVM. This was the patient. He came with the gradual progressive swelling in his neck on the left side for last 5 years, which was increasing gradually. And what we found in the CT angiography that it was an AVM, and the feeding artery were external carotid artery, and so finally we took control of the external carotid artery. We delineated the external carotid and common carotid, and we excised the complete arteriovenous malformation. This is the child, 13 years old child. She came with the swelling over the dorsum of right hand. She noticed it 3 years back, and gradually it was progressing, and we excised it completely. There was smaller arteries, palmar arteries were there. No major arterial involvement was there. We excised it completely with proper approximation of this scheme. This is again the patient who came with swelling whenever she does Valsalva maneuver or deep inspiration. She noticed that on the right side of her neck, a huge swelling appears. That was an abnormal communication between the external carotid artery and jugular vein, which led to the formation of the arteriovenous malformation in the anterior aspect of the upper neck. We excised it completely. We ligated the communication between the external carotid and the jugular vein, and we ligated the external jugular vein with no postoperative sequelae. This is again same patient, same type of patient who came, who was almost 80 years of age. He noticed that there is a swelling in his neck on left side for last 2 years. And what we found that it was a small nodular swelling which was arising from the external jugular vein. It was not having any communication with the arteries, but we excised it completely with the ligation of the external jugular vein. This was the patient, 16-year-old boy, who noticed that there is progressive swelling on his left forearm for last 6 months. He told that there is history of trauma from the cricket ball, but it was not the case. He was having arteriovenous malformation underneath the forearm muscles. And what we found that there was a huge AVM which had developed from the both radial artery as well as ulnar arteries. So after excision, and the wound was all right, and the swelling disappeared almost. This is the unique type of case in which we came across a patient who came with broken intravenous cannula after dialysis. It was not palpable, but when we did the color Doppler of the venous system of his right upper limb, then we found that in the mid arm there is the broken portion of the cannula was present there. So we anesthetized the patient under local anesthesia. We exposed the affected vein, and finally we took out the broken cannula and repaired the vein in the simultaneous manner after flushing the vein and removing all the clots around it. This was the unique case what I have come across during the COVID lockdown. This patient came from Sahibganj, and he went to surgical emergency in the midnight. He was admitted there. Next day, I got the call from the surgery department, and as per I remember, my teacher, Professor Vinay Pratap sir, he luckily got admitted under him, and he sent me the referral, and for the transfer, I transferred the patient. I did the CT angiography. What I found that all the facial artery, temporal artery, all arteries were involved in the formation of this arteriovenous malformation, and it was bleeding torrentially, just like anything. And there was a rain almost 0.5 to 1 centimeter over the apex of this arteriovenous malformation. So after going through the CT angiography, I found that there was just superficial arteries were involved. So I almost excised the entire arteriovenous malformation. And at the time of discharge, the wound was this. And after almost 2 months, patient came in my OPD with almost minimal scar over the forehead. So in conclusion, I would like to say that whenever the type of case, proper planning and timely intervention in the vascular cases is the best way to achieve the excellent result. Thank you.
Thank you.
Thank you, Dr. Rakib, for your brilliant presentation. and we have presented many number of cases in short time. Really great.
It's my privilege, sir, that I'm in front of you today.
Definitely.
Thank you.
One thing I have to say, Dr. Rakesh, you have presented your cases, lot of cases, very nice.
Sir, you have muted yourself. Please unmute.
But one thing I would say, I would like to say that you should have Rakesh, Dr. Rakesh, you should have hidden the identity of your patient.
Okay, sir.
One of the cases is recently 2-3 surgeons from Mumbai been punished for that.
Okay, sir. I'll make sure.
You should have hidden all at least patient's identity. We should have respected all those patients also. Okay, thank you.
Thank you.
Dr.
Thanks.
Dr. Vinay Pratap, sir.
Vinay sir is with me.
Yeah. Any from the
You unmuted yourself. You unmuted yourself. Hello.
Hello.
Hello. Hello. Yes, sir. Kindly say a few words, sir.
Yeah. Dr. Rakesh has presented his case, and he has done a number of surgeries in short time. We are grateful to him, and I thank you. He has been my first PG, and I am proud of him.
Definitely, sir. Definitely, sir. Dr. Ansul and Dr. Rakesh are doing tremendous job. They are ray of hope for Jharkhand, sir.
Yes, sir. Yes, sir.
Definitely, sir. We appreciate. Kindly accept. Kindly accept gratitude from the managing committee. Certificate for you.
Thank you. Thank you.
WhatsApp you also this thing. Thank you very much for.
Thank you very much.
I thank our chairperson, sir, Dr. Pankaj Bodra, and Professor Vinay Pratap, sir. Kindly accept our gratitude and this certificate for achieving the session. Thank you so much.
Thank you. Thank you.
Thank you. We are on to.
Thank you. Thanks a lot.
Now, I welcome you all to the final guest speech. Welcome Dr. N.K. Chaudhary, sir, for this speech. Our chairperson, R.D. Nagesh, Dr. P.P. Chawla, sir. Dr. R.D. Nagesh is MBBS and MS from RIMS Ranchi. He is an associate professor. He was associate professor in Mahatma Gandhi Medical College, Jamshedpur, and is presently heading the Department of Surgery in Mendirai Medical College, Palamu. He is a versatile general surgeon and is loved by his students and colleagues. Dr. P.P. Chawla, sir, is a MS FRCS. He is a senior surgeon from Jamshedpur. He worked in India and Jamshedpur, and he retired as a director, Teen Plate Hospital, Jamshedpur. Thank you very much, sir. Kindly take your chair. Nagesh, sir. Nagesh, sir. Nagesh, sir. Nagesh, sir. Dr. Nagesh, sir. Dr. Nagesh, sir, unmute yourself. नागेश सर आप अनम्यूट कीजिए नागेश सर अनम्यूट योरसेल्फ
पहली बात जो करते हैं
म्यूट कर देते हैं
वेलकम डॉक्टर नागेश सर। नागेश सर सुन रहे हैं? Chawla sir, kindly introduce our speaker.
It's a great pleasure to introduce Dr. Nalini Kant Chaudhary, who is MBBS MS. He served in the Health Department, Government of Bihar from 1978 to 2000. During this period, he has served as RSO and Registrar in the Department of Surgery, Bhagalpur, 1982 to 94. He has many publications in the various national journals. He was the organizing chairman of Jasicon in 2015 and chairman of ASI Jharkhand chapter 2018. He has been a well-known surgeon, very soft-spoken and excellent person. Though personally I met him only once, but I remember he's a great person. Now he is there to speak to us today on a very interesting subject, and I give the mic to Dr. Chaudhary to carry on. Dr. Nalini Kant Chaudhary.
Am I audible?
Yes, sir, you are audible.
Thank you, Chairman, sir, for the nice introduction, which I don't deserve, actually.
You deserve, sir. You more than 100% deserve, sir.
Hello, Susil. How are you?
Sir.
And Dr. Nagesh. So now I'm going to start by sharing my.
Yes, sir.
डॉक्टर नलिनी का ना तो नागेश बोल रहे।
नागेश दूसरा चेयरमैन।
Visible? Visible? Hello.
Blue therapy in cervical patients.
Is it okay now? Should we start now? Hello.
Yes, yes, I'm pulling.
Yes, please start.
Yes, sir. Make it full screen.
पूरा करो, स्क्रीन को पूरा करो.
Beautiful slide, sir.
Okay then. Respected Chairman, sir, and the delegates. Am I audible?
Yes.
So now I am going to speak on some very important aspect of our surgical patients, which is very neglected part of our practice. As we know that the gastrointestinal tract is the only source of water and electrolyte intake. So any disturbance created due to fasting or due to gastrointestinal lesion or in gastrointestinal surgery leads to water and electrolyte depletion. To start with, so I have already told you about it. The normal water intake is 1200 ml per day, whereas water from solid food is about 1000 ml and water from oxidation is 300 ml. इसको हटा कैसे हटेगा? The slide is visible or not?
Yes.
Yes, visible, sir.
Yes, yes. Please carry on, Dr. Saab.
The output is urinary output, daily output is 1500 ml, loss through skin and lung 900 ml, and feces 100 ml, that is 2500 ml. Now this also depend upon the climate. Normal fluid requirement in adult is 40 ml per kg per day. In children, first 10 kg, 100 ml per kg per day or 4 ml per kg per hour. Second 10 kg, after 10, second 10 kg, 50 ml per kg per day or 2 ml per kg per hour, and for rest of the weight, 20 ml per kg per day or 1 ml per kg per hour. The sodium requirement per day is 60 to 150 milliequivalent per day or 6 gram of NaCl per day. Potassium requirement is 40 to 60 milliequivalent per day, whereas glucose requirement is 100 gram of dextrose per day. Rate of flow of IV fluid, 15 drops of fluid is equal to 1 ml, thus 30 ml of 30 drops per minute. 1 liter can be infused in 8 hours, 45 drops 1 liter in 6 hours, and 60 drops per minute 1 liter in 4 hours. Causes of fluid and electrolyte imbalance, that is impaired intake, nasogastric suction, vomiting, and losses in third space. The maintenance IV fluid requirement. The aim is to provide adequate fluid, sodium, potassium, glucose to the patient on parenteral fluid therapy. 200 ml of 5% dextrose plus 500 ml of dextrose saline plus 5 ml of potassium chloride 15% in each 500 ml of fluid. The above combination will provide 2.5 liter of water, 78 milliequivalent of sodium, 50 milliequivalent of potassium, and 125 gram of glucose. That is the daily requirement. Preoperative intravenous fluid therapy. The aim is correction of hypovolemia and dehydration, correction of anemia, correction of electrolyte and metabolic disorder. Correction of hypovolemia and dehydration. Requirement of fluid in liter is mild dehydration, the fluid deficit is 4% of body weight. Moderate dehydration, fluid deficit is 6 to 8% of body weight, and severe dehydration, fluid deficit by more than 10% of body weight. The aim of the correction is to have 30 to 50 ml urine per hour. Choice of fluid. The fluid replacement depends on the nature of loss and hemodynamic status. Commonly used fluids are dextrose 5%, dextrose saline 5%, 0.9% saline, ringer lactate, colloid, and whole blood. Intraoperative fluid therapy aim is to avoid hypovolemia and hypotension to maintain proper tissue perfusion. Causes of hypovolemia are blood loss, fluid depletion due to third space losses, nasogastric suction, losses by evaporation, vasodilatory effect of anesthetic agent, and spinal anesthesia. Type of fluid required are crystalloid, colloids, and blood transfusion. Crystalloids are ringer lactate. It is the most physiological fluid with composition similar to body fluid. Due to presence of bicarbonate, it corrects acidosis. Isotonic saline. When large volume of fluid needs to be replaced rapidly, that is hypovolemic shock. 5% dextrose to compensate the fluid depletion during starvation to correct intracellular dehydration. Rough guidelines for calculation of volume of fluid. Correction of fluid deficit due to starvation. We have grouped it in three. Correction of fluid deficit due to starvation, maintenance requirement for period of surgery, and loss due to tissue desiccation or hemorrhage. Correction of fluid deficit due to starvation. The choice of fluid is dextrose 5%. The volume requires hour of starvation into 2 ml per kg of body weight. जितना देर खाली पेट रखेंगे into 2 ml per kg of body weight. Second is maintenance of fluid maintenance of volume for intraoperative period. Choice of fluid is ringer lactate, and the requirement duration of surgery in hours into 2 ml per kg of body weight. Am I clear now? Correction of intraoperative losses. The choice of fluid, ringer lactate and or normal saline. Minor surgery 6 ml per kg of body weight and major surgery 10 ml per kg of body weight. For rapid restoration of plasma volume to correct severe hypotension, the indication are sudden hypotension due to major blood loss till blood is available. The advantage, better and prolonged plasma volume expander. Disadvantage, more expensive, rapid and large infusion causes pulmonary edema. This is for rapid restoration of plasma volume to correct severe hypovolemia. Precaution, before starting colloid infusion, blood should be sent for grouping and cross matching. Judicious use of blood transfusion is severe. In severe intraoperative blood loss is often life-saving. Advantage, it is the most physiological way to replace blood loss. Disadvantage, problem of availability, transmission of various infection, reaction. When not to give blood transfusion, if blood loss is less than 500 ml, loss of 10% of estimated blood volume is well tolerated. Post-operative fluid therapy. The administration of fluid and electrolyte during the post-operative period depends upon the clinical judgment of the patient's status. No equation or formula is perfect in planning post-operative fluid therapy. Aim of post-operative fluid therapy is maintain blood pressure above 100/70, pulse rate less than 120 per minute, and urine output 30 to 50 ml per hour. Before planning for post-operative IV fluid therapy, the question need to be answered: when and how long to give post-operative IV fluid, how much IV fluid should be given post-operatively, which type of IV fluid should be given on the first post-operative day, which fluid should be given to replace additional losses, when and how long to give post-operative IV fluid. Till the patient is able to start oral intake of fluid, it may be none to a few hours in minor surgery, it may be longer after major surgery. How much IV fluid should be given post-operatively? The operative stress and post-operative pain leads to increased ADH secretion, leading to water retention with low urinary output. So on the first post-operative day, 1500 ml to 2000 ml fluid is required. Which type of IV fluid be given on the first post-operative day? In early post-operative period, there is increased secretion of aldosterone leading to sodium retention. Recommended fluid is 5% dextrose 1500 ml and normal saline 500 ml. Potassium is usually avoided in fluid for first two post-operative day. The reason is poor urinary output, catabolic response may cause release of intracellular potassium, and intraoperative or post-operative transfusion of stored blood may add large amount of potassium. Which fluid should be added to replace additional losses in post-operative period? Prolonged nasogastric suction, the causes are causes of loss, prolonged nasogastric suction, and or vomiting. In this case, normal saline or isolite G. Potassium can be added on third day if urinary output is satisfactory. Fluid loss due to enterocutaneous fistula, ringer lactate, loss of blood if more than 500 ml, colloid or blood transfusion. Sorry, loss of blood if more than 500 ml, colloid or blood transfusion. Thank you, sir. Hey. This was हटाओ ना. नहीं नहीं हो गया. Thank you very much.
Thank you so much, sir. Thank you so much, sir. I call upon our judges, our chairpersons to kindly ask some questions, to have some comment. PP Chawla, sir. RD Nagesh, sir. Am I audible?
Yes, you are audible.
Oh, I call upon our chairpersons to have some comment. PP Chawla, sir. Mute हो गए, sir. PP Chawla, sir, you have muted yourself. Kindly unmute yourself. PP Chawla, sir, kindly unmute yourself. Nagesh, sir, kindly have some comment.
It was a wonderful presentation, Dr. Chaudhary.
Thank you.
And I think, yes, you can continue, Sushil.
Yes, I think somehow we are not able to connect with our chairpersons.
Or take it that they are satisfied.
Sir, kindly.
Yeah, but it was a very important topic. I think many of the DNBs would have benefited from this very important topic, which is very neglected.
Very neglected.
And most of even the very established surgeons have very less knowledge about the fluids. So your talk was very important, and I think all of us have benefited from it. Thank you so much for this talk.
Thank you very much.
Sir, kindly accept this e-certificate on behalf of the organizing committee.
Thank you, Sushil.
Though we are not able to connect somehow to our chairperson, sirs, kindly accept this e-certificate on our behalf, sir. RD Nagesh, sir, and Dr. PP Chawla, sir. Thank you so much.
Dr. PP Chawla is there. I can see him, but I don't know what is the problem with him.
Unmuted
I can see him there.
Yes. Somehow he has unmuted himself. And he was trying to speak something.
Yes, sir is there. Yes, sir is there. Yes, sir, please.
I must say that it was an excellent presentation. Surgeons normally don't give much importance to the fluid therapy. And it's very important. And Dr. Chaudhary gave a very good presentation. And one can carry home message that one must learn this fluid therapy before embarking on any surgery or any such things.
Thank you, sir. Thank you, sir, for your nice comment. And thank you, Arunima, for your comment.
Thank you so much for presenting this. Thank you very much.
Thank you very much, sir. Thank you, PP Chawla, sir. Thank you, Nagesh, sir. Thank you, Dr. N.K. Chaudhary, sir. Thank you so much. I pronounce this session to be closed. We are now moving to the valedictory function. It will be in Hall A at 4:15 p.m. Kindly join us in the valedictory function.
Yeah.
Thank you so much.
Yeah, and thank you so much, Sushil. Sushil, I need to thank you as well. You have done an exemplary job, and he has got a surgeon on call duty, but we want you to be there for the valedictory. Please join in with your mobile phone.
Definitely.
And thank you so much for carrying the session so well and taking care of all our faculty. Thank you so much.
Thank you so much. Thank you so much.
I request everybody to join in Hall A. We will have the valedictory there. Thank you so much.